increase in testicular volume. So usually what you will see is that they don't expect any increase. If it's a pure Kalaman syndrome, we don't increase the testicular volume at all. But sometimes on treatment, we see that TB gone up to 8 ml or 10 ml. In that cases, we'll give a break in that. Generally, we reassess after 3 months. My experience has been that they are able to produce certain amount of levels which are there, but they are not going to reach a threshold beyond that. So many reversible cases may actually again need therapy on that perspective. So you have to be very cautious when you label somebody as reversible. Many times they may not have, they may have some GnRH neurons. My thought about that is that maybe you need 80% of them to have a complete fertility. You need 40-50% to have some testosterone, and 0% will be Kalaman. So they are in between those groups. They are like in between CDGP and permanent HH. They have some response. Rarely they will be able to have normal fertility, but ultimately they will need some form of a gonadotropic induction. I think the other big issue is about they talk about using gonadotropin during infancy to mimic mini puberty. That's a big work going on in Europe. And a lot of people talk about pubertal induction, definitely. But these are issues which also will have issues of cost in terms of therapy, giving multiple injections, and all those issues complicate the matter. We have experience of good number of patients who have even Kalaman syndrome. And once you give them a proper induction, they are able to achieve fertility in a reasonable number of cases. So this needs to be proven from that perspective before we really go ahead and make a case for that. But I think these are the way things are moving more toward the physiological one. And any experiences, Dr. Hemchand, you'd like to share on that? Yeah. Yeah. And the other big thing is that whenever you are inducing, you need to use both FSH as well as LH, because if you give only LH, it will cause intratesticular testosterone to go up, and that may damage the germ cells without the Sertoli cell protective effect. So I think that is the sort of a major thing which is there. Thank you, Dr. Rahul. And it's been great. So I think we'll give a big round of applause to Dr. Hemchand and Dr. Rahul, both of them, who will be leaving from here. Thank you. This slide.
So next we have a session on growth hormone beyond growth hormone therapy, and we have none other than Dr. Anurag sir to present on this topic.
Thank you, Dr. Prasoon. And this is a very, very important topic that we usually deal in this perspective about the use of growth hormone. And we all know that growth hormone is being used in wide variety of indications. And there are certain scenarios in which we tend to use growth hormone beyond the overall conditions of GHD. So this is what I'll be focusing about in that perspective about growth hormone beyond growth hormone deficiency. That's an important aspect to talk about. So when we talk about growth hormone, we know growth hormone has been used for a long time for various indications, but there are certain indications in which growth hormone has now been used extensively, and the responsiveness of growth hormone may be quite variable in that perspective. And if we see the classical indication is in the form of growth hormone deficiency, wherein it was used and it was found to have a good response. This looks like a busy slide, but what you need to focus on that there are multiple indications in which growth hormone has been used, and you find a good enough response. I'll largely be focusing about 3 major indications, that is Turner syndrome and SGA, with a bit about Prader-Willi and idiopathic short stature. We had a debate also on idiopathic short stature. So the main thing to remember is that, of course, GHD, you will have very good response. You expect a gain of around 10 to 15 centimeters in the first year, and then 8 to 10 centimeters in the subsequent years. With Turner syndrome, the responsiveness is 1 to 1.5 centimeter per year gain in terms of final height. And when we talk about SGA, the gain will be somewhere around, again, 1.5 centimeter per year. So this is something you need to really look at. So we'll talk briefly about Turner's, SGA, a brief word about Prader-Willi and ISS in that perspective. So when we talk about Turner syndrome, growth has multiple factorial effects which happen in the setting of Turner syndrome. One, of course, is the issue of the SHOX gene, which is the predominant determinant of growth in that perspective, causing intrinsic growth failure. So there is a component of skeletal dysplasia, which is there. There is also a long-term estrogen deficiency, which starts right from birth. So boys always have a lower level of estrogen than girls even during the prepubertal age group. So whether this estrogen deficiency in Turner's will be responsible for growth is an issue, and people have used various therapies on that regards. There's also an issue of hypothyroidism, celiac disease, which can also happen in that regards. So what can we do? We can, of course, give a pharmacological therapy of growth hormone in this indication. And there have been certain studies about whether giving a low dose estrogen is going to help out. And to increase the duration, we talk about modulation. So one modulation you can give is to delay the start of estrogen in that regards to get a good outcome from that perspective. There's also a role of anabolic agent like anabolic steroid like oxandrolone, which can also be used. Now, this is the normal growth pattern in Turner syndrome. They are reasonably okay. They are on the shorter side at birth, but they are not really short. Till around 3 to 5 years, their growth falters. And most girls will be short by around 4 to 5 years of age. So if you want to target, the best time to target will be around 5 years to consider starting growth hormone in Turner syndrome. If you delay, they will keep on drifting from that. And their final height will be like 20 centimeters short as compared to the mid-parental expectation. So this is like 130 centimeters will be the upper limit in terms of classical Turners in Indian girls. That's what we can talk about. So now let's go one by one about the case scenario. 6-year-old girl with short stature, height is minus 1.6 STS, FSH is marginally elevated. Now, FSH is not a good marker in prepubertal state, but if FSH at this stage also is high, that is a big pointer towards Turner syndrome. Of course, do a karyotype which showed an exokaryotype and was planned for GH. Now, what do we do in that perspective? So I'll base largely upon the Turner syndrome guidelines, which are there from the Cincinnati meeting. In that indication is not just short stature. Now, this girl is not short now, but she is destined to be short. So what they're talking about, not all people who are short, you can start even earlier. So growth velocity less than 50th percentile, who is short or who have a high likelihood of being short would require growth hormone therapy. There is no need for growth hormone or IGF testing in that regards. Now, if we go here, the screening workup was normal. Now, one message is always look for celiac and thyroid disorder before you really start about growth hormone in this perspective. The girl was started on 25 microgram per kg per day. Do you agree with this dose? This is a homeopathic dose as far as Turner syndrome is concerned. You don't expect any increase in growth velocity despite a good adherence. We should right away start with a high dose. So what do the guidelines suggest? The minimum dose is 45 microgram per kg per day. And I've seen this in many prescriptions that a lower dose is given. Anyway, the response is not going to be as good as GHD. So if you give a lower dose, you will have hardly any response happening. So this is the minimum dose. And in obese girls, often it is preferable to use a body surface area based dosing because then you will be giving a lower dose and you may cut in terms of cost in that perspective, in that regards. Now, people have done studies and seen that in older girls, it may be beneficial to use a body surface area-based dosing, which will give you a more efficacious plan. Now, on follow-up, her dose was increased to 55 microgram per kg per day, and she started developing headache and vomiting. Now, we say growth hormone is extremely safe because we're talking about usually growth hormone deficiency. And you are giving a physiological replacement. Here, you are giving a pharmacological therapy. At a high dose, you can expect more side effects. So side effects are more common in Turner syndrome. Be aware. And IGF-1 was done, which was plus 3.2 standard deviation score for age and gender. Now, the target or the upper limit of IGF-1 in GHD on treatment is plus 2. In Turner, you can keep it up to plus 3, but not beyond plus 3 because then you need to really worry about. And we often see more acromegaloid features like increase in feet size and other parameters may happen in that regard. So adverse effects include edema, raised intracranial pressure, unmasking of hypothyroidism, slip capital femoral epiphysis, glucose intolerance, and scoliosis, and they are much more common compared to GHD. But still the prevalence is not extremely high. I'm mainly worried about scoliosis. Many of these girls may have a scoliosis to begin with. So you need to be very, very careful in those girls about how they are progressing in that regards. And if you have a girl who suddenly was normal and suddenly complains of a knee pain, hip pain, difficulty in walking, that is the first sign of slip capital femoral epiphysis in this regards. As I said, you may have an increase in hand size. Knee is common in Turner syndrome and they may go up. I've seen hemangiomas go up, so be cautious about all those things which may happen. Rare risk of pancreatitis, but there is no effect as far as the cardiac aorta or other parameters are concerned, which is a major cause of concern in Turner syndrome. And importantly, there is an increase in lean mass. You don't have an increase in adiposity in that regards. So the target IGF should be below +3 SDS is what the recommendations are. So we reduced the dose to 45. There was improvement in symptoms, and IGF-1 now became 1.5 SDS, and now she was advised low dose estradiol. Now this is a girl which is very young, and some people we discuss now is that if your estrogen level is low, you may benefit from a estradiol. So what they're trying to do is ultra low dose estradiol. Is there a evidence for the ultra low dose estradiol? So this was the only study which was published in NEJM, a big NIH randomized trial in which they started at a very, very low dose of ethinyl estradiol, which was in terms of injection. And what they found was that the initial phase, there was a benefit, but in terms of final height, there was no benefit. So giving a ultra low dose estrogen in Turner syndrome girls is not recommended. So I think this is something which I will summarize based upon that. Now we go to another case. This is a 1-year-old girl with lymphedema. Now this is an early diagnosis. Unfortunately, we have usually a late diagnosis. What do you think is the average age of Turner diagnosis in our clinics? Anybody? 9, 10 is too early. Most of them come to us with delayed puberty. So if you talk about actual, it will be like 13, 14. If you saw in on-site, a lot of them come. So there'll be some who will come with short stature, but most will come with delayed puberty. In the US, till 5 years ago, it was 9 years. So the average age of diagnosis Turner's even there was 9 years. So we have even later presentation. But sometimes, like this girl comes to you at 1 year with lymphedema, and somebody has really thought that this could be something else. Her height is not short. She has got classical Turner syndrome. Now, the question is, do we treat now? And this was a big debate whether toddlers with Turner syndrome should be treated with growth hormone or not. And this study, initial data, now this is again interesting. So estrogen data, remember, in the initial phase, good response, but final height, no response. So the same thing probably came up with a toddler study also, which showed that there was a very, very good response if you started treatment early, which is expected. But at the end, the benefit is very, very minimal. So on final height, there was no significant difference between those who were treated from toddler or those who were treated from 5 years. You have given 3 extra years of growth hormone. Remember, this is a lot of injections, a lot of cost and other adverse effects, and not much benefit. So even if you gain a couple of centimeters, people really say that before, around 5 years before, it is not going to benefit much. So usually, that's why the Cincinnati guidelines say that you are either short or you have a high probability of being short. At 0.6 SDS at 1 year, it's better to observe and wait and watch in that regard. So NAH, the near adult height, was not significantly different in that regard. So they are saying 6 years of age is basically a good enough time. Don't start right away. But we need to pull down the time of diagnosis from 13, 14 to 6, because that's a major problem that we see. Now, this is what we usually see. A 13-year-old girl with delayed puberty, reasonably short, no breast, no pubic hair, classical Turners. Now, what do we do? Now, if you go by the guidelines, they say we should give growth hormone at least for 4 years before pubertal onset to achieve a reasonable amount of outcome. But this, at 13 years, are you going to defer the pubertal induction till 17 years is going to be a big question. So what are the options you can give? One is delaying pubertal induction, other is oxandrolone, which is a non-aromatizable androgen. It is not going to increase the bone age, but it is ultimately an androgen, so it may cause some clitoromegaly, it may cause some features of hirsutism which you need to watch for. So there are studies which have shown that if you give oxandrolone, you may not need to defer pubertal induction. This is the UK study, but there is very limited availability of oxandrolone, so we are not using it, plus the possible side effects. So androgenic side effects is going to limit that. So Turner syndrome, just to summarize, better would be to pick up early. 5 to 6 years is good enough. Don't wait beyond 5 years, because if you start at 5, the weight may be 20 kgs. If you start at 12, the weight will be 40 kgs. The cost will anyway be double. So this is something, treat early will be better. Don't expect a dramatic response. 1.5 centimeters per treatment year gain in final height is what you expect. So you treat for 5 years, gain around 7.58 centimeters is what you expect. The second group is the SGA, and in SGA we know that they have a high growth hormone in the fetal period, and they also have a postnatal growth hormone resistance. They also tend to have a early puberty. So SGA are short at birth. Those who are not catching up will not have growth, and then they will have early puberty. So this is something which you have to be really worried about. Plus there are syndromic associations which are also there in that regards. So you have a 5-year-old boy whose birth weight is 2.1 kg. You can see here, the child is short, the development and other parameters are reasonably normal. So what do you do in terms of the plan of therapy? Now, 85% SGAs will catch up by 2 years or maximum by 4 years. So the recommendations which Dr. Hemchand was talking about suggest that if a child is below minus 2.5 SGS by 2 years and minus 2 SGS by 4 years, that is the time they require evaluation. Now, that doesn't mean that you treat everybody, you at least evaluate in that perspective. This is the recommendation. So minus 2.5 at 2 and minus 2 at around 3 to 4 years of age. The 4-year-old girl, birth weight 2 kgs, normal development, she's short, she has dysmorphism and low set ears. What do you do? Now you will say, okay, this is SGA, not catching up. I'll screen for common conditions, correct nutrition, start growth hormone. But remember, there are certain conditions in which growth hormone is contraindicated. And if you are not clear about that syndrome, the recommendations are that you should consider for those genetic causes and genetic screening before giving growth hormone. And of course, when you're giving such an expensive treatment, you don't want to do any harm. So better is to really screen for high predisposition conditions like chromosomal breakage disorders. So do a targeted panel. You may find something which is a contraindication to GH. So this is the new message from the guidelines that before starting growth hormone, if you feel that there are dysmorphic features, better to get a NGS before starting treatment. And probably we are following this up and we are picking up some strange scenarios, which may not be a contraindication, but at least you know what the problem is. So this is an important thing to remember. Now, a 7-year-old boy who is SGA has normal faces in development, short stature, and what we are seeing here on growth hormone treatment should be given or not, or what sort of growth hormone should be given in that regard. So as we said, 4 years probably the reasonable time to wait. Beyond 4 years, not much waiting is going to be there. 33 to 67 microgram per kg per day is the appropriate dose. As far as growth hormone is concerned, you do not need to do a growth hormone IGF evaluation. But sometimes if you get a very, very low growth hormone, that may guide your dose. So if your growth hormone is low, lower dose will work. Growth hormone is high, you need a higher dose. So it's not routine recommendations, but sometimes we will be doing that. There are different guidelines. Generally, most countries wait till around 4, except the US. And the US are more liberal. They are starting very, very early at a high dose of growth hormone. But we cannot follow the same guidelines as Neha was talking about, that we have to look into our own country. So not everybody who is SGA not catching up. That will be like crores of people who will require growth hormone. But we should be focused. So somebody who's extremely short, we should give them an option in terms of severity. Now, what happens in terms of response? So just to summarize, we expect 1 to 1.5 centimeter per treatment year increase in growth hormone treatment. That's it. So don't expect a 25 centimeters increase. If you treat for 6 years, maybe 9 centimeters extra. If he was landing at around 150, he'll become 159. Don't expect that he'll go to 170. That is something which is important to understand. And the dose, as I said, is on the higher side. Now, on follow-up, growth hormone was increased. There is a rapid weight gain and there are metabolic concerns. Now, what is going to happen in terms of adverse effects? Again, adverse effects are more than GHD. But they are less than Turner syndrome. So if you look at the figures for benign intracranial hypertension, or if you look at slip capital femoral episodes, that was 1 in 400. This is 1 in 1600 treatment years, and other parameters are rare. Now, many people worry about glucose intolerance, but remember, SGA who gain too much weight will be more likely to develop metabolic syndromes. SGA who are not catching up are not at that much risk. So this is a different ball game we are talking about. The two trajectories for SGA, so to speak, in that perspective. So 11-year-old boy with birth weight of 2.4 kg with growth concern, extremely short, as you can see here, but has already entered into puberty. So this is something of a concern. Now, what do we do? Now, we know that the SGA will have earlier puberty and a more rapid progression of puberty. So when I'll talk about precocious puberty, I'll say that if you have a precocious puberty in a SGA girl, always treat. While SGA, non-SGA obese girl, you can maybe wait and watch. So this is something which is there. Bone age is already advanced and we need to really work out. So it's been shown that you may have a role of giving GnRH analog in this particular indication, and Hemchand also was talking about. And the guidelines say that if you have a predicted adult height below minus 2.5 standard deviation score at onset of puberty. So remember these figures, minus 2.5 at 2 years for evaluation and minus 2.5 predicted adult height at around the onset of puberty, you can give GnRH analog along with growth hormone to delay. So there is a clear-cut guideline which is now coming up in that regards. So we've discussed about the two common ones. What about Prader-Willi? Prader-Willi, what you need to understand that this is mainly for body composition, reducing body fat and decreasing adiposity. You need to have a genetically confirmed diagnosis. GH testing is not required, and you need to be very cautious with growth hormone because they have a tendency of obstructive sleep apnea. You should evaluate, treat that, and then only you need to go ahead with that. Start with a low dose and use a body surface area based dosing because you will be giving too much of a dose if you give a per kg dose in this regards. Very importantly, they have a severe sleep apnea, diabetes, or severe obesity. In that regards, you may have to avoid this. Monitor them for IGF-1 level, which should be upper half of normal. Do a sleep study in that regards. What about idiopathic short stature? Dr. Vijay had a very wonderful debate with Vibha. So it's already been covered. The key message is the indications are that height less than minus 2.25 STS after 5 years. So does that mean 1% of our population should give growth hormone? I think the answer is no. Somebody who's very short, you will treat, but maybe marginal cases not required. You need to evaluate for all known cause. Dose required is high. There may be some increase in height by around 3 to 5 centimeters, but at an astronomical cost. So in the US data, it shows $10,000 per centimeter gain in ISS. What I'm trying to say is that ISS basically, some people may have mild GHD, some people may have mild GH insensitivity. So you can't label every ISS as the same. Give them a trial for 6 months, see how much they are growing. If their growth velocity has doubled, maybe you continue. If not, you stop it. So if somebody is below minus 3 SDS, this would be my suggestion or approach that I follow. From that, minus 2.25 will be too much. That's like 1 percentile. To minus 3 SDS will be 0.199. So that will be like 10 times less. At least the burden will be less in that regard. So give a trial for 6 months. And if the height SDS is not increasing by more than 0.15 in the overall period, stop the treatment in that regards. There are also studies about the use of aromatase inhibitors, growth hormone in pubertal children. This has already been discussed. So this is some strategy which can be considered. So just to summarize, there is no role of growth hormone IGF-1 testing in non-GHD conditions. Pharmacological doses are required. You tolerate higher IGF levels. Response is not as excellent as GHD, and pubertal modulation becomes important also in that perspective. So I'll close the talk here and we'll be open for questions there.
Thank you, sir. It was a very crisp and evidence-based presentation. Very enlightening. Thank you, sir.
Thank you. So if there are any questions? So if there are no questions, we like to close this session. I'd like to thank Dr. Prasoon, who is the young endocrinologist in Kanpur, who has recently come up from AIMS Jodhpur. And it's good to have more people coming up. And Dr. Anshul, who has come all the way from Jhansi. I'll request Dr. Dhwani to hand over a moment to Dr. Prasoon. We'll have a quick break of 5 minutes for tea. People can get the tea and bring it up here. And then we'll start the second session about the adrenal disorders, which will be a case-based discussion. And that will be an interesting session. And so we will be restarting probably around 5 minutes from now, around 10:45. So you can bring the tea and maybe walk for some time. Okay, so we'll be starting our adrenal session. I'll invite the panelists for the session. We have got Dr. Ayesha Ahmed from Aligarh. We have got Dr. Manoj Agarwal from Ahmedabad. And we've got Dr. Dhwani Raitada, who is doing currently the CDR fellowship at Regency. And we will be focusing on the adrenal disorders, which are a very, very important group of disorders that we have to look at. And these disorders will basically have significant implications in terms of treatment and in terms of management as well. So what we try to do is that we'll try to focus initially with regards to the key aspects of each aspect of the particular disorder and then we'll go on to case scenario based approach. So this is the pattern that we follow for these grand rounds. So we have 3 grand rounds in this part of the advanced course and 3 in the basic course in this session. So we'll start off with this concept of this adrenal grand round. Welcome Dr. Ayesha again, Dr. Manoj and Dr. Dhwani. And we'll keep it absolutely interactive so that there is no more time for discussion in that regards. So we'll focus upon 3 common conditions: adrenal insufficiency, congenital adrenal hyperplasia, and Cushing syndrome. These will be the 3 common conditions to go onwards. So when we talk about adrenal insufficiency, we know the problems could be right at the level of the hypothalamus or pituitary, wherein there will be issue of either the corticotropin releasing hormone, the ACTH, a CNS problem. This will be associated with isolated cortisol deficiency because ACTH does not control the aldosterone effect in that regards. We have a normal renin-angiotensin-aldosterone system, and these children will not have pigmentation. So this is an important thing to remember. They will present to you with hyponatremia without hyperkalemia. This could be genetic, infiltrative disorders, or even exogenous steroids will present like that. The second rare but important group of conditions is ACTH receptor problem, in which your ACTH is not working. You will have pigmentation, you will have hypoglycemia, you will have hyponatremia, but again your potassium level here will be normal. So problems will be like familial glucocorticoid deficiency, mineralocorticoid receptor problem, or a AAA syndrome. Finally, the most lethal and the most dangerous form of primary deficiencies, in which you will have pigmentation with salt wasting, hyponatremia, and hyperkalemia. Problems could be at the level of steroidogenesis or at the level of adrenal hypoplasia, which are there in that regards, including hemorrhage and infiltrative disorders. So you should think of cortisol deficiency. I'm not talking about a combined glucoaminocorticoid deficiency. If you have hyponatremia, unexplained headache, hypoglycemia, fatigability, shock, or even hypercalcemia. The other way to think of it, if you have hypoparathyroidism, whose suddenly the calcium requirements are going down, you may think of development of adrenal insufficiency. So any individual who has type 1 diabetes and now the insulin requirement is going down, central diabetes insipidus where the AVP requirement is going down, hypertension where your blood pressure medication requirement is going down, and hypoparathyroidism where your calcium requirement is going down, think of a cortisol deficiency in that regards. And how do we diagnose? Importantly, isolated low cortisol is not diagnostic of adrenal insufficiency. It has to be in the setting of either stress, hyponatremia, or in the setting of hypoglycemia. So levels more than 550 at any point of time rule out adrenal insufficiency. If despite these problems, stress, your levels are not high, you are really worried about in that regards. There is a log linear relationship between ACTH and cortisol. So if your cortisol is low, your ACTH should be very high, at least about 300 picogram per ml. And this is adrenocortical. If the ACTH is normal also, this is a central cause, and central cause means you need to do an MRI and other parameters. One area where there is a lot of confusion is in infancy, wherein you have a lot of issues of sulfated metabolites, of fetal adrenal working. So levels are different and cutoffs are different at different age groups. So in the initial 2 to 3 days, you use a cutoff of 100, beyond which you use a cutoff of 70 nanomoles per liter and then 138 nanomoles per liter. So you need to use specific cutoffs. Remember that you will have other sulfated products. You use an extracted sample, do a GCMS based assay, There's no diurnal rhythm. So in infancy, you don't need to do a particular timed sample. So we always say do cortisol at 8 a.m., which is not required in infancy, and they may have a diminished response. So if you have a primary adrenal insufficiency and your ACTH is less than 300, this is central, you require MRI. More than 300 in a young child, think CH or steroidogenic defect. Beyond that, start thinking of a genetic or an autoimmune adrenal insufficiency in that regard. So we'll start with the first case. 12-year-old boy with liver disease. There is hyponatremia and hypokalemia. Urinary sodium is 10. Fluid overload is present. Cortisol is 50. Advised hydrocortisone. So this is a referral coming from the gastroenterologist. Dr. Dhwani, what do you think? Will you treat in this scenario?
If we look at it superficially, we may think of low sodium and low cortisol and inadvertently make the same mistake. However, one needs to understand that there is an underlying liver disease which will cause hyperalbuminemia and decrease CBG levels. So
what do you expect the urinary sodium in somebody who has hyponatremia if it is because of a cortisol deficiency?
High. We expect an SIDH-like picture, high urine sodium.
So this low urinary sodium means it's more like a fluid overload scenario. So it's a third space. So this liver disease is the primary cause of hyponatremia. So would you advise treatment?
No, we will like to do urine-free cortisol levels in case we are highly suspecting cortisol deficiency.
Yes. As Dhwani has said, in liver disease, if your CBG levels are low, you will have a lower, falsely low level of cortisol. In this scenario, you can use salivary cortisol or free cortisol where you will measure that. And if you look at the albumin, so this is not really a case of cortisol deficiency. So urinary sodium should have been high if you're thinking cortisol deficiency, and it may be falsely low in liver disease. Second case is a 3-week-old girl with failure to thrive, weight of 3 kgs, birth weight 2.7. So only gained 300 grams in this whole period. There is sodium of 142. So sodium is 142, potassium is 3.9, cortisol is 86. Now, the referral basically is again the same thing, that this is hydrocortisone requirement is there. Do you agree, Dr. Ayesha, with the diagnosis?
Yeah. Here, as you can see the picture, we have a 3-week-old girl who's not thriving, and you have been sent with a cortisol level which looks low. So looks like this girl has adrenal insufficiency, but in endocrine, always remember before starting any treatment, always look at the age appropriate cutoffs. So always, especially for younger infants and especially for newborns. So here the catch is you have a baby who is just 3 weeks old. So you have to look for age appropriate cutoffs before thinking about the next step. So as it was very rightly pointed that you have different cutoff levels at different age group. So you have to go for age appropriate test. And also you have to, for any hormone analysis, you always have to look what was the method of estimation. Oh, that is also very important because there can be many causes of false positives, especially in a 3-week-old baby who may have influence because of fetal effects, which may remain persisting. So because there can be many, the simple investigation and methods of estimation may lead to estimation of non-bioactive materials also like cortisone. They can be estimated and they might lead to false positive. So you always have to look for age-appropriate cutoffs and also the method of estimation of your hormone. That is very important.
As Dr. Ayesha said, that unless you have hyponatremia, hypoglycemia, then this cortisol will be significant. His sodium was 146, so don't give value to single. We get so many referrals of low cortisol in infants, which is nothing to worry about. 2-month-old boy with failure to thrive and again not gaining weight, hyponatremia and hyperkalemia. Slightly different from the previous cases, Dr. Manoj. Now, cortisol here is 60. So will you use the same cutoff which Dr. Ayesha was talking about? ACTH is 500, or do you think this is something else?
So here, if we see this case, then weight is okay. And if child is failing to thrive and had a hyponatremia with a low cortisol, with a high ACTH, we can tell that this is the adrenal insufficiency case. But we have to further do a workup for this case.
So this is a primary adrenal insufficiency. Yeah. So any hyponatremia, if you have a cortisol below 550, you start getting worried in that regards. Now, what you have done here, the most common cause is 17 OHP is normal. He has a testicular volume of 1 ml and SPL of 4.5. So he doesn't have any DSD. so to speak. So what are you thinking here, Dr. Manoj, now?
Yeah, so here what we have to do, we have to do a work. 17 OHP is normal. Then we have to do a CT. We have to do lipid profile, and according to that, according to adrenal size or according to lipid profile, we can do further investigation and we can put our diagnosis.
So in a young child, young male, if you have excluded CAH, an important differential is adrenal hypoplasia congenita, in which your adrenals are small. So you should do a adrenal imaging and you will find a small adrenal which was found, and DAX defect was found on that. So what are your key messages, Dr. Manoj, there?
So yes, if low cortisol is there with the in the context of the hypoglycemia and hyponatremia, then we have to consider adrenal insufficiency. And if 17 OHP is normal, then case we have to do workup for the lipid profile and for the adrenal size. If size is low, then we can tell that it is a DAX deficiency.
Thank you. 2-year-old boy with fever and failure to thrive, hypoglycemia, which is ketotic. There is hyponatremia and hypokalemia. Cortisol is 112, ACTH is 1200. So diagnosed as Addison's disease. Dr. Manoj, do you agree with this diagnosis?
Yeah, so according to previous case, as we discussed, this child is yelling that I am cortisol deficiency because at the hyponatremia, cortisol is very low with the ACTH. Now the thing is that here is it primary deficiency or is it a receptor issue? So here's there are the certain issue, the certain clues that we can catch. Like in this child, the potassium is not patient is not on the hyperkalemia. Potassium is near to normal. So we can tell that it is not primary adrenal insufficiency, but it is a receptor problem. So when we are in doubt, that time some pigmentation and normal and potassium will give us clue. Pigmentation you can find both in the primary adrenal insufficiency as well as the receptor defect. But the severity of the pigmentation will be very, very high in the receptor defect because there only you will have a cortisol deficiency. So here that clue we have to take.
So clearly we have got this scenario. It looks more like a ACTH resistance, like a familial glucocorticoid deficiency. So again, potassium will be normal if your ACTH is not there or it is not working. Pigmentation suggests ACTH resistance. Next case is a 2-year-old boy with feeding difficulty and fever with hypoglycemia and ketosis. There is hyponatremia and a normal potassium. Cortisol is 98. So this is low for the level of severity, has got pigmentation. Dr. Dhwani, what are you thinking of?
Again, like the previous case, this looks like an isolated adrenal glucocorticoid deficiency without affecting the mineralocorticoid. And the pigmentation suggests that ACTH levels are high.
So again,
ACTH
we have to go
resistance.
for, so we have to go for a ACTH resistance.
Yes.
Now, what particular findings can give you a clue in that regards?
Feeding difficulty suggests that it could go in the setting of AAA syndrome. So look for alachremia.
So whenever you have an isolated glucocorticoid deficiency, always look into specific pointers, whether the eyes are dry or not, whether there is a dysphagia, which is not, and this could be a AAA syndrome, which is the scenario of alachremia, adrenal insufficiency, along with esophageal abnormality or dysmotility. So primary adrenal insufficiency is unlikely with normal potassium. Look for eye and feeding pattern in this regards. 4-year-old girl with hypoparathyroidism, stable on calcium and calcitriol, now complains of irritability and constipation, and suddenly the calcium was high. The calcium was never even normal in this child, and now this child comes to you with hypercalcemia and hyponatremia. Dr. Ayesha, what is happening to this child?
Now here we have a girl who was a diagnosed case of hyperparathyroidism and who started on treatment. So again, always remember in endocrine, whenever you have involvement of one system and the findings, either clinical features, provided you have started the treatment, either the clinical features or your biochemical parameters are going haywire. No, you cannot explain. So always think involvement of other endocrine organs as well. So if you cannot, like you don't expect hyperparathyroid, like hypercalcemia, which is causing all these symptoms in this child. So always keep in mind, there might be association of any other endocrine involvement. So adrenal insufficiency definitely may go hand in hand. So you always have to keep that in mind and investigate for that. So
if you have a reduced calcium requirement in hypoparathyroidism, always consider that this could be a APS1
also
scenario.
the low sodium levels here. So always it should make you think, it should ring a bell. that it
So
should be.
hypercalcemia and hypoparathyroidism consider autoimmune cause, and calcium will normalize with treatment. Now we have a 12-year-old girl in ICU with fever, has a sudden deterioration, hyponatremia and hyperkalemia. There is a petechial rash. The child was doing fine, and suddenly the resident calls you and says, okay, this patient has gone into shock. And there is hyponatremia and hyperkalemia, and they say that there is a flank mass. So what are you thinking, Dr. Dhwani, there?
This is the classical picture of a child presenting with adrenal hemorrhage, often seen in the setting of meningococcemia, renal vein thrombosis.
So in this scenario, of course, this is classical case of a adrenal hemorrhage. And what do you expect in terms of the urine?
Hematuria may be seen.
Now, how will you manage this child?
So the child is in shock, so you will need fluid resuscitation because there is an glucocorticoid and mineralocorticoid deficiency. You start off with 50 mg per meter square hydrocort and followed by 100 mg per meter square infusion. When the hydrocort requirements come down, you can shift to hydrocort plus
So why are you
glucocorticoid.
recommending infusion? Most people prefer a bolus.
So what happens is the CBG has a certain binding capacity beyond which whatever cortisol is given to the system is excreted out in urine. Bolus doses therefore result in more loss in the urine.
So if your cortisol goes above 750 or something, you will lose that cortisol in the urine. So if you give a bolus, levels will go up to 1000, lost in urine, then come down. While if you give a continuous infusion, it will give you a much better scenario and picture in that regards. And as you said, you will taper over 48 to 72 hours and add other agents later on. So clearly, if you have shock with hyponatremia, this is adrenal insufficiency, flank mass in the setting suggests hemorrhage, and you give hydrocort infusion, which is preferred. 12-year-old boy with septic shock in the intensive care, somewhere a similar scenario, on multiple fluid boluses, on multiple vasopressors, the blood pressure is not coming up. So they have now given a reference to you because the cortisol level is 145, reported as normal. The lab reference is 130 and 550. So Dr. Manoj, do you think this requires some endocrine input?
Yeah, so as sir has discussed previously, this is the case of patient is in ICU. So it is in stress. Here the cortisol should be not 145, but it should be more than 550. So here and blood pressure is not increasing, vasopressor is not working. Then in the acute setting, we can give hydrocortisone supplements to resume for the resumption of the shock, for the resumption of the BP.
So this is clearly what is known as critical illness adrenal insufficiency. This may not necessarily mean that there is a hemorrhage. All your cortisol has been used up. So you don't have any store. So better to give them a physiological replacement and they will improve on that. So this catecholamine refractory shock, there is a role of cortisol. Physiological hydrocortisone will be helpful. From adrenal insufficiency, we'll move to the second important group of steroidogenic defects. So when do we suspect a steroidogenic defect? If there is, of course, an atypical genitalia, if you have precocious puberty, delayed puberty, salt wasting crisis, hypertension, or hyperandrogenism. So a combination of aldosterone deficiency or excess, androgen deficiency or excess, you will suspect various forms of steroidogenic defect. So if your mineralocorticoid is low and androgen is also low, so you have a XY-DSD with salt wasting, you are thinking of a proximal defect star, side chain cleavage, 3-beta-HSD and POR. If you have androgen deficiency, but excess deficiency of mineralocorticoid, but excess of androgen, you're dealing with 21-hydroxylase, 3-beta-HSD, POR, XDSD with salt wasting crisis. If you have a mineralocorticoid deficiency with a normal androgens, this is 11-aldosterone synthase defect. If your mineralocorticoid is normal and androgen is low, this is 17-beta-HSD. This is XY-DSD without salt wasting. If it's too much, it is aromatase deficiency, XX-DSD without salt wasting. Finally, if you have too much mineralocorticoid and androgen is low, this is 17-hydroxylase deficiency, XY-DSD with hypertension. If you have excess of androgens, this is 11-hydroxylase deficiency, precocious puberty in a boy with hypertension, or you have a XX-DSD with hypertension. And finally, if you have a normal androgen and only isolated aldosterone excess, you have a 11-beta-HSD2 apparent mineralocorticoid excess. So this slide will really summarize all the form that we are going to discuss. So 11-hydroxylase present with a XDSD and hypertension, or a male with precocious puberty, get a DOC done. 17-hydroxylase presents with XY-DSD with hypertension or a delayed puberty in female. 3-beta-HSD presents with salt wasting or XY-DSD. Star side chain cleavage presents with salt wasting XY-DSD in female delayed puberty. And POR presents with DSD in both XS and XY. Now, very interestingly, 3-beta-HSD, there is a high level of testosterone for a XX individual, which causes virilization, but it is not high enough to provide enough virilization for a XY individual. So you have DSD in both males as well as females in that perspective. And then we have got isolated defects like 17-beta and 11-beta. So 17-OHP is a very, very important test. And Dr. Sugandha talked about this yesterday. If your 17-OHP is below 300 nanogram per DL, CAH is unlikely. Above 3500 CAH is more likely. And then in between, think of variants. Otherwise, you do a ACTH test to identify the diagnosis. So clearly, interpretation of 17-OHP levels will give you the right diagnosis in that regards. Often we are now being called because of neonatal screening and causing confusion. 17-OHP, if it's less than 300, it makes it unlikely. About 1200, then you should ideally do a repeat test, because this is a screening test and it has a high sensitivity, low specificity. So do a repeat 17-OHP electrolyte and consider a genetic testing. In between, you can think of some other forms of DSD. So we'll go on to cases again. Day 1 neonate on screening. 17-OHP is 1400 nanogram per DL, 14 nanogram per ml. Advise hydrocortisone. So Dr. Dhwani, what do you do in this case?
So day 1 is not the ideal time to screen a neonate for CAH. Beyond day 3 would probably be preferable. So we would like to repeat the test again after 72 hours.
So it is too early. So what are the false positive causes of high 17-OHP?
There is increased sulfated products in the immediate newborn period, stress on the day.
So if you have a stress, if you have an infection, early sample. And what are the causes of false negative 17-OHP? If
somebody has given hydrocortisone, then
if mother has received steroids, antenatal steroids are given, that may cause suppressed 17-OHP also. So in this case, we should do, you can reassure or you do a TMS sample again in that regards. So screening should be done after 72 hours and GCMS based assays may be required in these scenarios, particularly from that regards. Day 10 child now came with the day 14 child with DSD, they are bilateral gonads. There is no uterus. So this, if you look at the DSD, this is classically a XY DSD. You have got very low level of testosterone. Sodium is 123, potassium is 6.6. So, Dr. Ayesha, what are you thinking about?
So looking at the baby looks like, for a normal person, looks like a female. But if you see, you can see the scrotum is underformed, and you can see rugosities as well. So we have the first thing definitely would be the go for karyotype, but we have the report with us, that is 46XY. So as Sir very rightly pointed out in that flow chart, that you have to look for two things. One is the mineralocorticoid, whether that is in excess or deficiency, and another is the androgen. So here in this case, we have androgen that is definitely going on the low side, and also the mineralocorticoid that is on the deficiency side. So that helps you to come down at a diagnosis of the first thing, that is the 3-beta-HSD or star, depending upon the other.
And 17-OHP levels were in between the range. So
between.
that's why we are thinking of a 3-beta-HSD defect here. So clearly, if you have a XX-DSD with salt, XY-DSD with salt wasting, you think of 3-beta-HSD as a possibility. So I think that's very important. Androgen deficiency and aldosterone deficiency means a proximal defect. High 17-OHP in the setting suggests 3-beta-HSD. 3-month-old boy with micropenis and inguinal hernia referred for surgery has hyponatremia mild and hyperkalemia mild. Cortisol is slightly low, ACTH is high. So there is a primary adrenal insufficiency. Head circumference is only 32 centimeters. So there is microcephaly. This is the child. And there is a micropenis. So there is microcephaly. Dr. Manoj, what do you think here?
So here the case of adrenal insufficiency with the head circumference like microcephaly, and you can see in the picture there is upturned nads. So here I think it is very, very clear that it is a case of SLO. You have to go for the lipid profile first, and if the cholesterol level is low, and lipid profile is deranged, then you can label it as a SLO.
So this is a very, very important scenario. You have an upturn near micropenis. There is a mild cortisol deficiency and your cholesterol is low. This is Smith-Lemeli-Opitz syndrome, where your cholesterol is not being formed. If you don't form cholesterol, how will you form other forms? But it's not an absolute deficiency. Some amount of cholesterol is formed. So that's why they have a milder defect. So micropenis and mild salt wasting things, Smith-Lemeli-Opitz, low cholesterol levels are there. 8-year-old boy with early puberty, height is 134, so very tall for an 8-year-old. Pubic hair stage 4, has hypertension and hypokalemia. And very importantly, what you're seeing is that there is hypertension, hypokalemia. I am not given 1 point, but what do you think out here?
So here, this is the case of early puberty. So we have lots of differential diagnosis here, but the main point here, there is a aldosterone excess is there. Alkalosis with the hypokalemia with the hypertension. So here we should have to think about CH. And if we can think about hypertension, then we do have 2 DD. One is the 17 OHP and one is the 11 hydroxylase deficiency. But in the male, if it is causing the precocious puberty, then our DD could be left as a 11 hydroxylase deficiency.
So I think that's a very important point. So if you have a XY individual with precocious puberty and hypertension, that's 11 hydroxylase deficiency. And that's something which you have to be really important in that regards. 14-year-old girl with delayed puberty. Now we have a different manifestation. Boy with precocious, girl with delayed puberty. She is having height of 148. No breast, no pubic hair. She also has got hypokalemia, and then workup showed alkalosis. Hypertension is present. So Dr. Dhwani, a girl with sexual infantilism, hypertension and hypokalemia.
So again, in contrast to the previous case, we can see that for a girl who has not attained puberty, this child has a reasonable height. In the setting of delayed puberty here, we would like to look for palpable inguinal gonads because that will be a clue.
Yeah.
And if they are present, then we would like to consider in the diagnosis of 17 hydroxylase deficiency here.
So inguinal gonads were present. So you have a situation of high mineralocorticoid, but low levels of androgens, which suggests 17 hydroxylase deficiency. So if you just keep this algorithm in your mind and you just look at the patient carefully, you will make the correct diagnosis in this case. So again, 17 hydroxylase deficiency, delayed puberty in female with hypertension. So always check blood pressure in a girl who comes to you with delayed puberty. What are the other causes of hypertension and delayed puberty, Dr. Dhwani, in a girl?
Turner syndrome can be one of those
Yes,
reasons with
and
coarctation of aorta.
Something very important which we should not miss. Chronic kidney disease.
Yes.
So that also we have seen patients with hypertension. They can present like that in that regard. So delayed puberty plus hypertension is 17 hydroxylase deficiency. XY DSD, think if gonads are there. If gonads are not there, it could actually be a XX DSD. You can also say in that regard. So we have discussed a lot about the variety of steroidogenic defects. We will now move towards the adrenal excess and Cushing syndrome. So Cushing syndrome can either be ACTH dependent, more likely before puberty. In older children, you will be more likely to have a ACTH dependent cause, which is usually because of an adenoma. And this is what you call as Cushing's disease. Rarely you can have hyperplasia, more common in children. And adenoma usually has a gradual onset. You will have classical features of Cushing syndrome. You may have pigmentation. On the other hand, you can have ectopic forms, which are less common in children. And there you will have rapid development with pigmentation. You may also have hypokalemia and alkalosis because whatever steroid is there is overwhelming the capacity of 11-beta-HSD2, causing a mineralocorticoid effect, causing the same hypertension and hypokalemic alkalosis. And they don't have time to develop these features, so they don't have this classical Cushing-White features. Rarely you can have a receptor defect because of McCune-Albright syndrome, in which you have a GNAS1 problem, or you can have a primary pigmented nodular adrenal disease in which you have a normal size adrenals. So normal size adrenals with a ACTH independent cause is basically a Carney's complex or primary pigmented nodular disease. If you talk about ACTH independent cause, you're talking about adrenal adenomas, or very importantly, carcinoma, which present with virilization. Typical presentation is a female individual who will present to you with severe hirsutism. You will have muscularity, clitoromegaly, change in voice, testosterone over 200, and you will get a large carcinoma in that regards. So you should think of Cushing's if there is growth failure with obesity, stria, low bone mass, hypokalemic alkalosis, hypertension. Classical features like round faces, buffalo hump, they are not very common in children. More common is short and plump child. This is something you should always be aware about. You can have hypertension, hyperandrogenism. I have seen psychotic behavior also in some cases, which can become a big problem, and of course, recurrent infections. When you want to assess cortisol, remember that it has a diurnal rhythm. Level is highest at the morning, lowest at the night. So if you are really looking at deficiency, you should look at the night time. So you can do a midnight cortisol. We don't really do a morning, evening cortisol anymore. You can look at urinary excretion, which is difficult in children, but 24 excretion is a good one. If it's 3 times the upper limit, that is basically Cushing syndrome. If midnight cortisol is high, that is significant. And finally, you can have variations which will happen in that perspective in that regards. So you can do an overnight DEXA suppression test in which you give dexamethasone at night and see the levels in the morning, and you will go. Very importantly, the test should be decided based upon the conditions. So in a pregnant woman or somebody who is on estrogen, the overnight dexamethasone suppression test should be avoided because here your total cortisol level will be high. Do a urinary free cortisol. Liver disease and nephrotic syndrome, again, your binding globulin will be low. Do a urine-free cortisol. Renal failure, you cannot use a urine-free cortisol because the excretion will be less. Do a ONDST. Incidentilloma, we want to diagnose symptomatic cause of hypercortisolism. Do a DEXA suppression. And in antiepileptics, dexamethasone metabolism may go up. Do a urinary free cortisol. Obesity and other causes, do a overnight suppression. So based upon condition, decide about the test. If you're suspecting Cushing's, first of all, you confirm it and exclude exogenous cause. So we always do a morning cortisol if the level is low, that is exogenous Cushing's. If you have confirmed Cushing's and ACTH is less than 5, this is adrenal cause, get a CT done. If ACTH is above 15, get an MRI done. MRI shows a lesion about 6 mm. This is Cushing's disease. Smaller lesions, you should go ahead with IPSS, which will give you a diagnosis in that regards, or rarely ectopic ACTH. In between levels of ACTH, we do a CRS test to make a diagnosis. So Cushing syndrome is a major undertaking. Most children who are coming to with features of Cushing syndrome actually have what is exogenous Cushing's. So get a cortisol basal first and then you make a decision. But once you diagnose Cushing's, you have to diagnose this could be adrenal carcinoma. This could be a large pituitary adenoma. So you can't miss out on that. So we'll now have a 16-year-old girl with obesity and hirsutism. There's menstrual irregularity. There is buffalo hump. Overnight suppression shows a cortisol level of 150. ACTH was borderline. So MRI was advised. So Dr. Ayesha, what do you think here?
Again, here is a catch here. Based on the findings that we have, this is looking like a clear-cut case of Cushing's. But the catch is the girl has obesity and hirsutism. So you never treat the report, you treat the patient. So you take a good history and you always take history because as you saw in the chart, there are many drugs which can affect your hormone analysis, the cortisol levels. So always take history if the child is on any drugs or not. So if once you take a detailed history, the girl was actually for hirsutism was being treated with some.
So this is a very common referral,
Common,
and they might be on estrogen and progesterone, and your morning cortisol is very high, and even non-suppressed sample will come. So in this case, you should not do a ONDST.
ONDST and go for urinary free cortisol.
That will be the way forward, and UFC was normal in this case. So your cortisol level will be high with estrogen. Preparation, UFC is the preferred test. 15-year-old girl with obesity with no Cushing-White features. Again, overnight suppression is 140. She is having an underlying seizure disorder. And Dr. Dhwani, what do you think is happening in this regards? What could be the possibility?
So in this child, anyway, the pretest probability of having Cushing syndrome is much less. Moreover, again, as ma'am has already mentioned, there are drugs that can interfere with your cortisol assays. So we know that certain anti-epileptic drugs are enzyme inhibitors and may enzyme inducers and may decrease the effect of dexamethasone that was given to suppress cortisol levels, resulting in under-suppressed.
So always remember that
we
if you are on any drug which is inducing P450 system, your dexamethasone will be metabolized. So it's not going to suppress your cortisol and your test will be falsely positive. So on anti-epileptic drugs, you should do a
urine-free cortisol.
urine-free cortisol. So again, choosing the right test becomes important. So false positivity can be because of anti-epileptic drugs. Recommend a urine-free cortisol. 14-year-old girl with obesity, there is blood pressure of 120/80, mildly elevated or not really elevated, pigmentation. 8 AM cortisol is very high, 900 nanomoles per liter. Somebody got excited, got a ACTH which was 20. So this looks like a ACTH dependent Cushing syndrome. MRI show the pituitary adenoma. So now they have been referred for surgery and they have referred you for evaluation, Dr. Manoj. What do you think is happening here?
Yeah, so this skull is a little bit looking like that it is fitting in the Cushing syndrome, seeing the obesity, BP, pigmentation, high cortisol with the ACTH with MRI. But the thing is that before labeling anybody as a Cushing syndrome, we have to do second screening test, and then we have to do confirmatory. Then we have to do ACTH. So actually, cortisol has a diurnal variation. So sometimes you can find very high result. So that need to be confirmed. And here we need to do dexamethasone suppression test, and by that after that we can do ACTH and the MRI. So unnecessary investigation was done. That was the main message there.
So I think we need to understand the difference between a screening test, a diagnostic test, and a classification test. Morning cortisol, the honorary role is to exclude exogenous cortisol provision, which has been done in that case. Now, if your morning cortisol is high, that does not mean anything. Get either a ONDST, UFC, or a midnight cortisol. If they are suggestive, then you go ahead with a second confirmatory test, and then you go ahead with a classification test, which is ACTH, which will give you whether it's a ACTH dependent or an independent etiology. So this is not a good test to go forward. So no role of morning cortisol. Do the test in the correct sequence. That's important. Screening should be done with ONDST in that regards. We have a 12-year-old girl with obesity. Height is 142, weight is 60 kgs. You can see this girl out here. Looks pretty Cushing-wide. I think overnight suppression shows 120 nanomoles per liter. So this is their ACTH is 6 picogram per ml. MRI show the pituitary adenoma. Now, what do you think, Dr. Dhwani, is happening in this case?
So yeah, the pretest probability of having Cushing's is high. The overnight dexamethasone, okay, screening test is positive. So even the diagnostic test was positive here, sir.
Yeah. So what we are looking at is that you're looking at pituitary adenoma. My main concern is why is the ACTH only 6?
Okay. The assay, how it was sent, how it was collected could affect the ACTH levels. And perhaps in someone where we have a high index of suspicion, it may be better to repeat ACTH levels here.
Yes. This is a classical case of Cushing syndrome. All the features are there. You have adenoma. Now this ACTH is 5 to 10, which is a borderline scenario. But this could pretty much be because of a non-transport of the sample in a proper fashion. So if you had done it using ICE, your repeat ACTH was found to be high. So again, you're going in this direction. Otherwise, 5 to 15, you would have to do a CRH test. So better to do a second ACTH before you go ahead in that regards. And then you have got Cushing's disease. So key message is pubertal onset is mostly because of Cushing's disease. Pre-pubertal is more because of an adrenal issue. ACTH is temperature dependent. Confirm levels if there is a conflicting reports. Now we have a 1-year-old boy with weight gain. There is hypertrichosis and round faces. You can see this child looks like a Cushing syndrome classically. Cortisol is extremely high and there is no reduction after a DEXA suppression. ACTH levels is 0. So Dr. Ayesha, what are you thinking of? Is this etiology different from that girl which Dhwani talked about?
Yeah. So in this case, as you can see, the clinical picture and the biochemical picture is supporting the diagnosis of Cushing's and ACTH. So next step, once you confirm the diagnosis, the next step is always you look for whether that is ACTH dependent or independent. So considering the age, you have to think of adrenal causes as the primary pathology, and being the ACTH in the undetectable range. So definitely your diagnosis and your next level of investigation will be directed towards looking for adrenal causes.
And as very early onset, think adrenal carcinoma. So 2 ages, infant And somebody, girl around 14, 15 years of age, think of adrenal carcinoma. So ACTH independent, get a CT adrenal infantile onset suggests adrenal carcinoma. 14-year-old girl with hirsutism, rapidly progressive, clitoromegaly with hypertension, testosterone is 300, DHEAS is sky high. So you are finding very high DHEAS, urine-free cortisol is very high as well. So Dr. Manoj, what are you thinking here?
So here, the patient having a hirsutism with rapidly progressive. So rapidly progressive word comes, then we have to think about something very sinister pathology is going on. So, and the testosterone and DHEAS is fitting into the tumor range. So in this case, I will think about the tumor rather than the going and another thing.
So this is a classical presentation of an adrenal carcinoma, wherein you will have a rapid progression with virilization and ACTH will be low. You will have no suppression with dexamethasone. And there was a large tumor which was present. Again, a very, very sinister scenario. So virilization, male range testosterone, think of an adrenal tumor. Pigmentation will be absent, of course, in this regard. I think this is the last case. 1-year-old girl with shock after fever. She was doing fine and suddenly she had some fever and she went into shock. Now, she looks Cushingoid, but cortisol level somebody did was low. So this is an unusual scenario. What do you think is happening here, Dr. Manoj?
So here a patient has had a Cushingoid appearance, but the cortisol is very, very low, which is not fitting into the Cushing syndrome. So here we have to think about the exogenous Cushing syndrome, because in 1-year-old girl, which is might be exogenous steroid replacement can cause the iatrogenic Cushing syndrome. So that perspective we have to think about, and low cortisol is supporting our diagnosis.
So when we looked at the exogenous causes, they denied any oral medication. Then you did a very careful examination. You found that the thigh skin was thin and it was whitish in nature. So what do you think was going on?
Might be they have applied some for the rashes that pediatricians or some GPs are generally giving the cortisol cream. So might be that patient was applying that, and because of that, we have a picture of the exogenous Cushing syndrome.
So they were told sometime that if you have nappy rash, you can apply this steroid cream, and then they were applying it for many months, couple of months. The skin had become thin completely. That's because of the local effect. And this cortisol was getting absorbed, and that absorption caused a cortisol deficiency. And that's why they don't have enough stress response and they will go into shock. So you need to have a gradual withdrawal. So the key message is if you have features of Cushing with a low cortisol, think of exogenous, do a gradual withdrawal in that regard. So I think we have tried to cover the entirety as far as the adrenal disorders are concerned. I will like to close the session here. I like to specifically thank Dr. Ayesha, who has come all the way from Aligarh, Dr. Manoj all the way from Ahmedabad, and Dr. Dhwani for this wonderful discussion, and hand over to Dr. Dhwani for the subsequent session to start off.
Our next session starts on ovarian disorders. And for the next session, I'd like to invite the chairperson, Dr. Neena Gupta, who is professor and head of Department of Pediatrics at GSVM. I'm sorry, I'd like to invite Dr. Neena Gupta, who is professor and head of Department of Obstetrics and Gynae at GSVM Kanpur. Ma'am has done her MBBS and MS Obs Gynae from SNMC Agra and completed senior residency from Safdarjung Hospital, New Delhi. She is the owner of President's Guide card by a Guide Award by Honorable President of India, achieved Certificate of Appreciation by IMA on International Women's Day. She's achieved Certificate of Appreciation on occasion of National Safe Motherhood Day. Got felicitated for eminent teacher by Professor Murli Manohar Joshi. She has delivered the D-Kuti oration on COVID care at UPCOG. Got a Corona Warrior Award by Mayor of Kanpur and IMA Kanpur. She is the recipient of Top 21 National Women Achievement Award and Aparajita Samman by Amar Ujala. Academically, she's published more than 60 papers in journals of national and international repute, and more than 40 papers presented in various conferences at state and national levels. She has supervised more than 60 students as a thesis guide and co-guide, and has been as a chairperson and panelist speaker in various conferences and workshops. She's a master trainer of PPT CT program, laparoscopic tubectomy, communicative care of newborn and SIF PSA, comprehensive abortion care, MIYCN, new contraceptives, emergency
I think it's not needed to read all this. It's not needed.
Thank you.
actually.
Welcome, ma'am.
Thank you.
We
Thank you.
request Dr. Vibha to kindly felicitate the question. इधर आ जी।
The next chairperson for the session is Dr. Aarti Singh. Ma'am has completed her MS Obs Gynae from GSVM Kanpur. She is currently working as a consultant in Obs Gynae at Regency Hospital. She has special interest in high-risk pregnancies and obstetric critical care. Welcome, ma'am.
Request Dr. Vibha to kindly felicitate.
I would like to request the chairperson. Yes, I would like to request the chairpersons to invite the first speaker. Thank you.
And yeah.
Hello. It's my privilege to introduce Dr. Yutika Sharma Bajpai, who is a consultant reproductive medicine, pediatric and adolescent gynecology at our hospital, that is Regency Hospital, Kanpur. She is director of a Regency IVF and Gynae minimal access and robotic unit. She is the first one to, she is the first one to be doing this robotic surgery in Kanpur in obstetrics and gynae. She needs a big round of applause for that. And above all, she's a very nice person. She is a motivator for me. It is she who has motivated all the way for last 15 years. And I'm really privileged to be associated with her. Thank you.
Thanks a lot, ma'am, for such kind words, and coming from stalwarts like you, it really gives me a lot of encouragement. My topic today is basically on management of girls with hypogonadotropic hypogonadism. I'll be talking about how to induce their puberty and how to basically, what are the fertility options available for them. Now, this subgroup of delayed puberty girls is very special because their gonads are normal and they can have normal fertility. How we are going to do our pubertal induction is very important. And because they go for their pubertal induction to the endocrinologist, to the pediatric endocrinologist specifically, it's very important for us infertility specialists that we have a good dialogue happening amongst you and us. So I'm not going to go into details of the etiology of hypogonadotropic hypogonadism, but definitely there is constitutional delay, there are acquired causes, but we are most interested in the idiopathic form of hypogonadotropic hypogonadism, which is the Kalaman syndrome and the, basically all the other genetic causes and also the functional causes, that is the anorexia nervosa and all the others. So they generally would present as delayed puberty, disruption of puberty, which is basically onset of thilaki is there, but more than 4 years, there's no menarche, primary or secondary amenorrhea. And our congenital patients generally present with delayed puberty or primary amenorrhea. If a patient is presenting with delayed puberty for more than 18 years, it's most likely going to be idiopathic hypogonadotropic hypogonadism, and the delayed, the CDGP is completely ruled out. So coming on to why we want to basically importantly induce their puberty. even if it is CDGP. So if you have a 12 to 13-year-old girl, and these days we have so many anxiety disorders for very minimal things. So imagine a girl with no breasts, not having periods, to be fit in with the girls of adolescent age group. So it's very important to take care of their psychosexual health besides their future fertility. So their current goals are also very important. So what are the goals of pubertal induction? Definitely we want to have natural development of breast and uterus for their optimal size and growth, for their future fertility, as well as their current goals as well. We want them to have a good adolescent growth spurt. We don't want to give them a very high dose of estrogen straight away so that their bones fuse and they don't have their final height, which is too short. And then that's the time for acquiring peak bone mass, and estrogen is a key hormone. And finally, also their psychosocial health, which is very important for their growth, psychological health, and avoiding all the other disorders that come with it. So what are the pubertal induction regimes? So if you look at all the steps, most important, when to start. So 12 to 13 years, usually these patients don't present at that age. So all patients of delayed puberty generally present quite late to us for pubertal induction. And they're diagnosed late. Similar case would be of hypergonadotropic hypogonadism, something like a Turner syndrome. Those patients present quite early because they have other features of, short height and sometimes even the Turner syndrome classical features. In them, it's very important to, and that's for the gynecologist, that to involve the endocrinologist because they are short height, and if we start pubertal induction too early in them, you can have a poor final height. So it's very important for all the other cases of hypogonadotropic hypogonadism, start as soon as they come. Now, how to start? Start with a very low dose, 10% of the adult dose. Go slow, gradually built up. So try to mimic the natural puberty, which happens from Thilaki to Minaki. It's 2 to 2.5 years. That's what we want to mimic. Small monthly increments. And progesterone is one drug that we adult gynecologists are very, very used to because we are afraid of unopposed estrogen causing endometrial hyperplasia and future cancer. But in this particular case, we have to take our hands away from progesterone for a very long time because progesterone will actually interfere with the final uterine size and the final breast size. So estrogen, after 2.5 years of estrogen or when bleeding starts, add progesterone. And if the starting dose of estrogen is too high, there will be quick development of endometrial, periods will start early. We'll have to start progesterone early and it will compromise. So it's very important how you start, when you start, and how to progress. So what are the estrogens available? We've got the oral estrogen available. In India, we don't have the patches, but we have some of the transdermal estrogen also available. So with the oral estrogen, the drug first goes to the liver and then goes to the blood and then to the target organ. And in the liver, with the first pass metabolism, it interferes with all the other things and causes of all the side effects. With it lowers the IGF-1, so the growth spurt is lesser, thrombosis, dyslipidemia, and hypertension. So all the side effects of estrogen comes with the oral one. So the drug of choice would be transdermal for us because it avoids. Now the drugs available, oral, we've got the ethinyl estradiol, the estradiol valerate, and the conjugated equine estrogen. We also have 17-beta estradiol as oral preparation for all the, infertility specialists know about it. It's quite costly. We have the topical, we've got sprays available. We've got creams available for 17-beta estradiol in our country, but we don't have the patches. So the oral medication of 17-beta estradiol, it comes by the name of Estrabet. There are many generic Indian versions also. It's a bit costly compared to other estrogens that are available, but because it's an active drug, it has lesser of the side effects. It's also available in a transdermal form, the estrogel spray and the cream, and it gives, say, about 1.25 grams of the cream will give you 750 micrograms of the drug. So that's the preparation which is available. Estrogel spray is available. It's a metered dose one. Why I'm telling you this? Because it's very difficult to follow the protocols of pubertal inductions that are given in the books and that we use, because the kind of preparations that are available to us. So very difficult to dose them. So estradiol valerate, everybody knows, it's very easily available. Progainova, the dosage is 1 milligram, 2 milligram, but it has got all the unfavorable side effects that I was talking about. We've got Linoral available, not freely available, but you can ask the company to make it available. The dose that we require, 2 microgram, is not available. So 10 microgram is available. So very difficult to dose it. And CEE in the past, many senior pediatric endocrinologists must be aware of the conjugated equine estrogens, Premarin, but we are not using it very frequently now because of all the other ones available. So the equivalent dose of giving in pubertal induction is basically 1 milligram of 17 beta estradiol is equal to 1 milligram of valerate, Progainova, 10 micrograms of Linoral, and 0.3 milligrams of Premarin. So the dose that is generally recommended is 10% of adult dose. Adult dose is 2 milligrams for both valerate and estrabet, which means that we'll be giving 20 micrograms as the starting dose for these patients. So oral 7, this is Professor Jacqueline et al. From Melbourne Royal Children's Hospital. Her regimen is with oral 17 beta estradiol, commence around 12 years of bone age for Turner syndrome and as soon as possible for HH. And then starting dose is 0.5 milligrams, which is 50 micrograms, alternate dose, which comes around 25 micrograms per day for 6 months, and gradually increase it by 0.5 milligrams daily and 1 year of 1 milligram. And, once 2 years of starting the dose, in the last year, start doing scans, look for endometrial thickness, and add progesterone only when the periods start, or it's at least 2.5 years after the start of estrogen. Now, how much progesterone to be given? It is at least 12 to 14 days to prevent the development of endometrial hyperplasia. Modified regime, I will not go into details, but people have modified them in various ways and got optimal results from point of view of breast and uterine size. Future fertility studies are not available because it's so rare that these, patients generally go to that age, and, we don't have studies available. Now, this is for the transdermal patch. We don't have the patch. With patch, it is easy because you can cut it into 4, halves, 1/4 of a patch for 4 days, and that kind of regimes. We are talking with a lot of industry people for making the patches available for induction, but these patients are so less that they are not in the agenda. Coming on to with Linoral, definitely in the past, we had 2 microgram available. That time it was easy, but with a 20 microgram and 10 microgram tablet, very, very difficult to use this regimen because it's very difficult to. One thing that we used to do is to, break the tablet into powder and then divide it into 10 parts and then give it. So which is a very, very organized way of giving it. Progesterone, again, we've got 4 types of progesterones available. The physiological one is micronized progesterone, but giving it orally causes a lot of side effects, especially postural hypotension and even these things, but it's most physiological. It's most costly as well. Medroxyprogesterone, norethisterone, both these drugs are, synthetically prepared progesterones, are androgenic, have side effects of thrombosis, and norethisterone given at a very high dose can be hepatotoxic. So those are the things, but it is very cheap and easily available. And for the other one, the dydrogesterone, this drug has very minimal side effects, but it is quite costly. So these are the progesterone. The minimum dose, as we said, is 10 milligrams for at least 12 to 14 days. But it's not needed that you give it every month. If you're giving every 2 months, every 3 months, then also it is able to prevent development of endometrial hyperplasia. So pubertal induction in uterine size, there are many studies available. Now, the policy is to use the double lock policy, which means that you are giving it gradually with a low dose, not start progesterone unless you have an endometrial thickness of at least 8 mm. So in the last year, so after 2 years of estrogen, do the scans to look at the endometrial thickness. And if it is 8 mm, the better policy, and if you've not reached your Tanner 4 stage of breast, And uterine size, as I said, 6x4x3. So if that optimal size is not there, then you can actually decrease the dose of estrogen. Go slow. Instead of, adding progesterone, decrease the dose of estrogen, and then basically add progesterone only when your desired clinical results are there. So we have to be very, very careful, and that job is going to be the endocrinologist's job to give them optimal size breast, optimal size uterus to have a proper sort of a development as far as their fertility is concerned. So how do we monitor? So you all know about the monitoring. We have to look for the side effects. We have to see whether our dose is right or not. It's not needed to do the bone density scan so frequently, but it would be a good thing to do it once your periods have started. So see that how much bone accrual has occurred. And if it is low, in conjunction with the endocrinologist, we generally want to make their bones better. Now, coming on to the management, I'll just touch base with the infertility management in these patients. So we all know they have got some problem with either the hypothalamic region or the pituitary region, but their gonads are normal. Now, some key features for the gynecologist and for the endocrinologist here, management of fertility for all the hypothalamic causes, the pituitary is normal. So GnRH, it's not available with us, but GnRH will work. For pituitary causes, only we will have the gonadotropins that will work. So for the gynecologist, it's very important that in pituitary, sometimes it's isolated gonadotropin deficiency, but other times it could be a multiple pituitary hormone deficiency. So if you've got a patient with hypogonadotropic hypogonadism with you, it's very important to rule out other causes. So you rule out whether there is the thyroid axis is also compromised, the adrenal axis is compromised. So involve the endocrinologist. Very important, because these patients will not respond to GnRH therapy. The replacement for thyroxine and cortisol should begin before you go ahead for the ovulation induction. And sometimes these patients will require growth hormone as well if it's a complete multiple pituitary hormone deficiency, and that's why they don't function. Now, very important point in patients of hypogonadotropic hypogonadism, AMH and antral follicle counts are low. And very frequently, if you're not doing the workup properly, we can actually label them premature ovarian failure. And then, we'll very quickly send them for ovarian donation cycles and IVF when they can, get their own eggs. So AMH and antral follicle count in these particular patients do not give a proper assessment of ovarian reserve. And that should be actually interpreted in terms of what the LH and FSH is. And if the LH FSH is low normal, then we need to retest these patients. Coming on to, because congenital hypogonadotropic hypogonadism includes Kalaman syndrome and other syndromes, when you are offering them fertility with their own oocytes, it's important to get a genetic counseling done, because it could be, something that is transferred to the, so all the other things like prenatal testing and everything can be done if they are tested for the actual gene, what is causing the disorder. It's not mandatory though. I'll just touch base on gonadorelin. It's available in Europe. It's not even available in US, not available with us. So it's a, pulsatile therapy. And besides hypogonadotropic hypogonadism, it can be used in a subgroup of patients of polycystic ovarian syndrome, the ones who have functional adrenal hyperplasia and who've got the peak GnRH pulses being very, deep, and that's why they do not ovulate. In both patients, if you use the pump for a year, there is almost 90 to 95% success rate with this therapy, but it doesn't work for pituitary patients. Coming on to our, I'll just skip this one. So we'll come to the ovulation induction with gonadotropins because it's available in our country. And the gonadotropins that we use is generally human menopausal gonadotropin, because we require both LH and FSH in these patients. So we all know for the gynecologist, baseline low level threshold levels of LH are required for follicular development. So if we just give pure recombinant FSH, it's not going to work for them. We've got the Menopur, which is specially designed for this purpose, but we also have urinary HMGs available, various brands available. Cost is somewhere between 900 to 1,000 rupees per vial per 75 IU. Now, these patients require on an average about 3,000 to 3,500 international units for a single egg. So it's very costly treatment for them. We also have a more physiological version called Pergovirus available, where we don't require a lot of LH. So it's a 2:1 ratio. I think Pergovirus would be the drug of choice. Basically, one of the other things with infertility management in these patients is that if we look at the development of oocytes, so oocytes don't, I was talking about AMH and AFC. So once the primary follicles are becoming antral follicles, first is the stage of a microscopic antral follicle. So I'll just skip base and come back to this one. So I'll come to this one. Basically, the antral follicles of 2 to 5 mm are the macroscopic antral follicles that we can see on ultrasound. Actually, these are the follicles that are actually making the AMH. There are microscopic antral follicles as well, which are somewhat gonadotropin responsive. So growth from primary follicle to antral follicle, the Graafian follicle microscopic, is gonadotropin independent. But to grow from there to become macroscopically, so from 100 micrometer to 2 millimeter size follicle, that growth takes about 60 days, 2 months prior to ovulation, and is gonadotropin dependent. And because these patients have no gonadotropins, that's why they don't have this growth happening between the microscopic and macroscopic antral follicles. And that's why the antral follicles, if you do after an HRT treatment in these patients, we don't see any antral follicles. And they look like pseudo premature ovarian failure patients. Their ovaries look small. So it's important when we give basically ovulation induction in these, sorry. So can I go back? Upper? No. Lower. So coming on to ovulation induction, when we do ovulation induction, in a normal patient, it's 10 days of stimulation. The follicle is there and you do the timed intercourse or egg collection or whatever the plan is for the fertility. Here we have to at least give 20-25 days for the follicles to start growing. So start with low dose, 75 international unit, and see this thing weekly. And if you don't see the follicle, don't increase the dose. You have to keep on giving the threshold levels. Once you start seeing the follicles, that's when the dose should be increased. And that's why we require a very careful. Sometimes if a patient has MPHD, we have to start giving them, we have to give them even, basically growth hormones. Now, because these patients have no endogenous LH surge, they won't have any premature ovarian ovulation. So no need to give any down regulation in these patients. Trigger has to be high dose. Don't give agonist trigger in these patients. Not going to work. And especially if it is a pituitary failure. If it is a hypothalamic disease, agonist will work. And then whatever treatment fertility you are doing, ovulation induction, timed intercourse, IUI, IVF, do that. Luteal phase support is must. So they will form a corpus luteum, but that corpus luteum is not going to be sustained because they don't have any endogenous LH. So these are some key features in their ovulation induction that you will have to give a very stringent luteal phase support. Otherwise, pregnancy won't happen. So that's important. The key features, better success of isolated because they have the intact LH FSH system. Once you there is some low level threshold level LH being there, so they work better compared to MPHD. Prolonged stimulation is needed, and AMH is definitely a better predictor than AFC. Don't go by AFC here. So that's one condition where we don't look at AFC. Even though nature doesn't want us to interfere. The other thing that I really want to say is that with gonadotropins, definitely careful dosages are very important because you can have a hyperstimulation, you can have ovarian hyperstimulation syndrome, everything happens. Even multiple pregnancy is poor prognosis in these patients. We've done a pubertal induction in them. Their uteruses are not naturally made. So definitely we want to give them only a singleton pregnancy. Growth hormone, we use growth hormone for our MPHD patients. So adjuvant growth hormone in ovulation induction along with gonadotropin in this subgroup is really works wonders and results. So so in MPHD patients, generally you will want to give them HRT for at least 3 to 6 months prior to, if they are not on continuous treatment. If they're already on continuous treatment, we can begin. Definitely cover for the thyroxine and the adrenal excess. Growth hormone has to be started prior to the ovulation induction, at least for a minimum of, so it has 15 days and it has to be continued till the first trimester, throughout the LPS and in the first trimester to have the best results. This is optional, but definitely IGF-1 levels give us a good idea that our growth hormone is in the right phase. Gonadotropin stimulation, as I said, if you're doing an IVF, a high dose, low dose, if you're not doing, and then this is the study. I'll just skip based on this and come to take-home messages. So very important that pubertal induction has to be started at the right time with a low dose, with small increments and addition of progesterone, a little later to have final breast and uterine maturation. Late onset pubertal induction, more than 16 years, actually compromises the final height. So that needs to be sent for pubertal induction, or pubertal induction started as soon as the diagnosis is made. And in this population, it is class 1 and ovulation, very high success rate, both for ovulation and pregnancy. I skipped because it was a little delayed, but the study was showing it. Thank you.
We would like to invite comments or questions from the audience, please.
First of all, I would like to say that it was a very comprehensive and very informative talk. And I want to ask how many patients you have encountered like this. HH is not, not very common, but it's common also. So how many patients you have encountered in your practice?
So actually we are running an adolescent clinic here. So I get a lot of patients from Anurag. So we transition patients from the pediatric age group to adult age group. So I have got almost like 10 patients who have transitioned. Walk-in patients are very less, because generally they are diagnosed as, ovarian failure, and then they go in for IVF. So that misdiagnosis is very common. And otherwise, if the pubertal induction was not done properly, they are all missed, actually. So I get more commonly the hypergonadotropic hypogonadism. So I have got 5 pregnancies with Turner syndrome. So that is, we did, for one of the patient, we did the pubertal inductions ourselves. So Anurag did the pubertal induction. That patient got married, transferred to me, and then we did ovulation induction for her. And she also had male factor. So we did IVF eventually for her. And she has a baby. She had coarctation of aorta as well. So it was a very difficult pregnancy. Then there are other 3 patients conceived, hypogonadotropic patient was there, conceived naturally on ovulation induction. So I have got 4 or 5 patients with me, but a lot of patients for pubertal induction. Generally, these patients are very difficult in our social scenarios. They don't get married. Very, that fertility thing is a little something to continue with me. It becomes a bit difficult. Yeah.
Aarti ma'am, any comments?
It was an excellent presentation in a nutshell.
Thank you.
Do we have any questions from the audience, please? If not, I would like to request the chairpersons to invite the next speaker for the session, please. Thank you, Yutika ma'am.
Thank you.
Now I want to invite Dr. Anurag, the backbone of this workshop, I think,
Dr.
for giving his talk on precocious puberty.
Thank you, ma'am. So we'll start off with the case of precocious puberty. And this is a scenario which is very, very commonly encountered in pediatric endocrine practice and also in gynecology practice, but there are a lot of confusions which are there. So we'll try to use basic case-based approach to highlight the importance. So we had this 7-year-old girl with thelarchy who had a stage 2 breast development. She had no periods and had a pubic hair stage 1. She was a normal height individual and a bone age was normal. So this girl was referred to me for evaluation and management of precocious puberty. The key point here is that she is not tall. Now, we normally expect every girl who is coming to us with precocious puberty to be tall. She is not tall, which is a bit of a concern. Bone age is also normal, which is unlikely. Now, she was recommended GnRH analog by other clinicians. And when we did further evaluation, we found that the vaginal mucosa was red. So as I said that this child did not look like precocious puberty. So the best thing is to look at the vaginal mucosa, which will tell you if it's pale, it means that it is pubertal. If it is red, it means it's prepubertal. So what actually was happening here that she did not have a true breast development. It was only a lipomastia, which was misdiagnosed. So we have cases which are misdiagnosed and we have cases which are missed. So this is something which we want to really highlight. So precocious puberty is reasonably common. Approximately 0.2 to 2.5% of all girls will have precocious puberty. 90% of this will be physiological and 10% will be pathological. But it does not mean that the physiological will not have an impact on their height. The major concern is their final height. Our aim is to identify these disorders and to identify the girls who will need treatment to achieve a good height, while not unnecessarily giving treatment in other scenarios. So just a brief overview, you know there are 3 major organs and 3 major hormones which are regulating the pubertal development. So the GnRH coming from the hypothalamus is continuously being suppressed before puberty using the negative signals which are GABA and MKRN3. And in appropriate situation and age, and if the body has enough nutrition, the GnRH will then go and act on the pituitary to produce LH, which predominantly acts on the theca cell to produce androstenedione, which is aromatized via the FSH-dependent aromatase into estrogen. So in a girl, you need both LH and FSH to produce estrogen, while in boys, only LH alone may be good enough. This is something which is very, very important to understand. Now, estrogen acts on the estrogen receptor to cause effect on the breast, on the growth plate, as well as the uterus. So a major effect of estrogen is to cause growth acceleration and bone age acceleration. So if you have a high estrogen, you will have a rapid bone age progression. Child will look tall, but she will land up short if you do not do intervention. That's the key message that I'd like to give, especially for the gynecologist colleague out here. Now, adrenal is another organ which is producing DHEAS. This is a source of androgens. So gonadarchy and adrenarchy are 2 different terms altogether. So breast development and pubic hair development are 2 different facets of physiology. If we should not always think that they will go side and side, and there can be different issues in that regards. Very importantly, TSH has got structural homology with FSH. And if your TSH levels are extremely high, it will act on the FSH receptor to produce ovarian cyst. That will result in peripheral precocious puberty in a short girl. Every girl with precocious puberty is tall. If you have a girl with precocious puberty who is short and has large ovarian cyst, this means this could be hypothyroidism, which I'll highlight subsequently in that regards. So problems can happen in the central scenario, and this is regulated via the adipocyte. And adipocyte, if you have got enough leptin, it will then say body, okay, this is the time to go into puberty. There is also a peripheral production of estrogen via the adipocyte. So in obese girls, you may have an earlier onset of puberty. But very importantly, in many of these obese girls, thelarchy will happen, but there will be a very slow progression. They will not progress very rapidly. So you have to decide whether you want to treat them or not. On the other hand, if you have a small for gestational age, lean individual with precocious puberty, this is a rapidly progressive puberty. Because you expect puberty to be delayed in somebody who is undernourished. If they are already undernourished and having early puberty, it means it's something wrong out there. So BMI becomes an important criteria. Just a few words about pubertal assessment, and the most important parameters to look at are breast stage 2 and breast stage 4. So breast stage 2 is just any papilla elevation, but always differentiate it from lipomastia. Approximate your thumb and finger. If you find a resistance in the areolar area, that's true breast development. Otherwise, it's a lipomastia. From here, the girl will start growing and she will have around 2.3 years mean from B2 to B4. And then from there, she will have vaginal discharge and menarche. The average growth from stage 2 breast is around 20 centimeters. Average growth from stage 4 breast is around 10 centimeters. And average growth from menarche is around 5 to 7 centimeters. So always put height and add that and see what is happening. So if you have a 130 centimeter girl at B2, she will be around 150. If she is at B4, she will be 140. But if she is having menarche, she will be 135. So you need to just look at the actual pubertal status and then decide whether intervention is required or not. Vaginal discharge means in the next 6 months, you will most likely have periods in that regard. Now, pubic hair progression is independent of gonadorrhea. What I'm more concerned is about P3, stage 3 development. Stage 2 development may be physiological. So if you have long, pigmented, curly hairs, that's a sign of progressive puberty. P2, wait and watch, don't do unnecessary workup. And of course, stage 4 and 5 becomes important from that perspective. Now, very importantly, we need to understand the hormonal course of progression. And we know very well that the FSH levels remain high in the prepubertal stage. And they increase by 2 to 3 times during puberty, while the LH level increased by around 20 times during puberty. So which is the best marker for pubertal status in a girl? It's LH and not FSH. So if you want to do one thing, look at LH. If your LH level is more than 0.2, newer assays, 0.2 is very good. That is pubertal. Less than 0.1 is prepubertal. What about reproductive organs? Now we need to understand that there is a growth of ovaries and uterus. And the first change in the uterus which happens during puberty is the change in shape of uterus from a tubular structure to a globular structure. Then your length will increase above 3.4 centimeters and then endometrial thickness will start to appear. So looking at ultrasound is a very, very important tool in this perspective to identify in that regards. If your length is above 32 millimeter and not centimeters, 3.2 centimeters, I would say, volume is more than 2 ml, this is puberty. Precocious puberty in girls can be either incomplete, only breast, only pubic hair, only bleeding, or it could be complete. Now, if you have isolated menarche, this is not really a precocious puberty. This is a local cause. No breast, no pubic hair, only vaginal bleeding. This is trauma, tumor, abuse, infection, all other things, not endocrine. If it's complete, it could be central in most cases where it is idiopathic. But if the onset is before 6 years, you need to think of a CNS lesion in which there could be a pathological cause, rarely genetic disorders. Peripheral precocious puberty because of an ovarian cause is rare. It usually is associated with ovarian cyst, and you can very rarely have adrenal tumor. So most of your cases will be isolated thelarche or pubarche or a idiopathic central precocious puberty. You do not need extensive evaluation in that regards. The question is it precocious puberty? If it's precocious puberty, is it complete or incomplete, central versus peripheral, and what's the cause? So precocious puberty in girls is defined as pubarche and thelarche happening before 8 years of age or menarche happening before 9.5 years of age. This is what you need to really understand. Now you can assess pubertal status using estrogen, but estrogen at low levels is not reliable. So you may have normal levels also. What I will more rely is vaginal mucosa. If the vaginal mucosa is pale, it suggests that you have a estrogen exposure. If it's a red mucosa, it means it's a non-estrogenized vaginal mucosa. Endometrial thickness above 2 mm, growth acceleration and bone age acceleration. And this is very important. You have a tall girl, but her bones are much, much more advanced than that. So this will result in a final height which is compromised. And of course, discharge and abdominal pain will give you a clue. Now, whether it's complete or incomplete, if you have only breast development, this could be an isolated thelarche, but this could also be a progressive puberty. So you have to really look at here what might happen subsequently. If you have only pubarche, this could be idiopathic. It could be CAH or rarely adrenal tumor. So how much is the adrenarche? How much is the DHEAS level? That will give you the clue. And finally, if you have isolated bleeding, this is trauma, tumor, and abuse in that regards. So if you compare central versus peripheral, you have to look at a LH level. If LH is above 0.2, this is suggestive of a central precocious puberty. We don't usually now do a GnRH test in that regards, but you can do it in certain scenarios. Very important clinical clue, look at breast, look at pubic hair, and you will get a diagnosis. You have only pubic hair, no breast development. This is adrenal problem. It's not a ovarian problem. No breast, no pubic hair, bleeding. This is a gynecological problem. If you have breast development, but you have got no pubic hair development, this is hypothyroidism. You have normal breast, normal pubic hair development. This is a central cause. This is a central precocious puberty. So a combination of this will give you a clue clearly in that regards. Now workup includes gonadotropins, and if you need GnRH analogs, if the LH is pubertal and a girl is below 6 years, get an MRI done. If it's a prepubertal LH, do a ovarian and adrenal imaging in that perspective. Bone age is essential to see the height compromise, and thyroid also becomes important in scenarios along with an ultrasound from that regards. So the approach, if you have only pubarchy, get a DHEAS done. If DHEAS is normal, this is nothing to worry. It's an idiopathic phenomena. If it's in the adrenarche range, wait and watch. But if it's very, very high, then you should think of CAH. So DHEAS, very, very important in a girl with precocious pubarchy, because this could be adrenal tumor or CAH. If vaginal bleeding, local cause. If it's a complete or thelarchy, get a bone age. Bone age is retarded. Most commonly, this is hypothyroidism. Bone age is normal. This is slowly progressive. Bone age is advanced, then this could be central versus peripheral. So I would say look at clinical clues. You will get the diagnosis in most cases. Club with bone age, you will get the diagnosis again in that regards. So this is the case I already discussed. 7-year-old girl falsely labeled as precocious puberty when she only had a lipomastia. So just by doing clinical examination, you would not have done any test in this girl. 2-year-old girl with thelarchy, clear-cut breast development, which is happening. Onset 6 months ago, this is slowly progressive. Stage 3 development, which is there. Now, this could be isolated thelarchy. So what we recommend is that get a LH-FSH. If LH is normal and ultrasound is normal, don't worry. Most girls presenting between 1 to 3 years with just breast development do not need extensive management. But do document their LH. Do get an ultrasound to be sure, because this could be a hypothalamic hematoma also, which is causing the same thing. But this is a simple isolated thelarchy. Now, other case, 2-year-old girl with vaginal bleeding, thelarchy 3 months ago. So a recent onset breast development, and then you had a bleeding. She is having no pubic hair development. So this is a strange scenario, and bone age is advanced. So in this case, I will be worried. If you have very rapid onset menarche within 1 year of thelarchy, this means it's a hyperestrogenic state. Estrogen is hugely high. You can see LH-FSH is low. So this is coming from the ovaries. So this case, clearly you have an ovarian cyst, and then you think of macunal bed. Then the other workup will be done by the endocrinology colleagues. 1.5-year-old girl with menarche, breast stage 2, no pubic hair development. She's tall. And what you're seeing, again, the LH is very, very high. So I have already said that most girls with early puberty at 1 to 3 years may be normal. But menarche is not normal at 1 to 3 years. And you are seeing very high LH and FSH. This is something pathological. And MRI showed a lesion, which is known as hypothalamic hematoma. Now, hypothalamic hematoma is a normal tissue in an abnormal area. It does not require surgery. Do not refer them to a neurosurgeon, because they will ultimately go for surgery, and this can cause a lot of confusion. So again, diagnosis of hypothalamic hematoma is important. 7.5-year-old girl with pubarchy, birth weight 2200 grams. So she is a SGA, small for gestational girl, who now is gaining weight, has breast development not there, but pubic hair development, and DHEAS is marginal. Very common presentation, SGA girls have insulin resistance, and this leads to the development of precocious pubarchy. They may develop PCOS and other things later. At the moment, however, DHEAS is not very high. I will follow up, advise weight loss in that regards. On the contrary, 6-year-old girl with pubarchy who was non-SGA. This is important, non-SGA. She is much more taller than the previous girl, has got a very high level of DHEA. So this girl requires evaluation. This could be an adrenal pathology, and this turned out to be CAH. So you need to understand what is physiology and what is pathology. That becomes very, very important in that regards. 7-year-old girl with vaginal bleeding, 1 episode, no breast, no pubic hair. Vaginal mucosa red, diagnosis. So it's a local cause. We're not talking about an endocrine cause. And this happened to be a foreign body. So all those things have to be considered. So a gynecology referral is important. 6.5-year-old girl with menarche, last 1 week she had thelarche. So very recent thelarche and menarche. She is okay, not very short, not very tall. She has got no pubic hair development, no cafe au lait spots, 0 LH, 0 FSH, high estradiol. So what does it mean? There was a source of estrogen recently, which produced a lot of estrogen, and then it went off, and that's why you had a withdrawal bleeding. So this is a classical presentation of a functional ovarian cyst. So always look at breast and menarche, you will get the diagnosis there in that regards. 7-year-old girl with thelarche, 3 months of age, she is extremely short. First sign, short girl with precocious puberty raises an alarm. She has a large ovarian cyst. And in fact, she was being referred for surgery. And when we saw the child, she had all the features of hypothyroidism. So this is a child who is short, delayed bone age, large ovarian cyst. Think of hypothyroidism as a possibility. TSH is more than 100. Now, I'll just summarize here and probably stop in a couple of slides about management. Now, management is very good with GnRH analog treatment, which is there for girls. But what you need to remember is that you should not give it to everybody. If somebody is below 6 years of onset, 100% treatment is required. Between 6 to 8 years, if the bone age is very advanced, then only treatment is required. Otherwise, you don't need to treat. GnRH analog will basically desensitize the pituitary. You will have initial flare and then the levels will go down. And what you are expected is that you need to give at the accurate timing very importantly, because if you delay, they will have flare every time. So when we say 12 weeks, it is 12 weeks. Don't give it at 14 weeks because then your whole treatment will fail in that perspective, and that becomes important. It has no effect on pubarchy because that is coming from the adrenals. And in somebody who is intellectually having a problem like cerebral palsy, you just want to control periods, we give medroxyprogesterone acetate, but it is not going to benefit in terms of height. It is bad for bones. So it's not a good drug overall. So just to summarize, for treatment of precocious puberty, if the age of onset is 6 years, don't worry, you need to treat. If the age of onset is about 8 years, no treatment is required. 6 to 8 years, and if you have progressive puberty, that means you're tall, your bone age is too advanced, or you have a uterine features of a size above 34 mm or an ET of 5 mm, this is clearly treatment is required. Otherwise, you follow up for 6 months to really make a diagnosis if they're progressing to treat. Otherwise, treatment is not required. So age, uterus, bone age, only 3 things you will need to do in terms of achieving the treatment. This is very, very important. Most of your girls will actually come somewhere around here. So follow up. But yes, 20-30% will come at the wrong time. And if we don't treat them, they will have short height. And when they come to us, it is too late for us to do anything. So don't treat unnecessarily. But when it is required, we should have an immediate referral also in that perspective. And the preparation that we normally use in this setting are essentially the leuprolide is the most common preparation which is used. And the usual dose is approximately 11.25 milligram, which we give around 12 weekly. If a girl is presenting very late with menarche, do not start on a 3-monthly preparation, start on a 4-weekly preparation to allow less flare. Otherwise, the bleeding will be too much. The other options were triptorelin, goserelin, and hystrelin, but now leuprolide is the one which is very easily available with reasonable cost efficacy. And you expect breast to go down, growth to become normal with no effect on pubarchy. We expect a height gain of around 10 centimeters if it's below 6 years, and around 6 centimeters if they have onset between 6 to 8 years. So you need to be thinking of it. But every time you give GnRH, you will have a flare. So you have to be cautious in that regards. So I think we have really covered. So the key messages I like to give with regards to precocious puberty in girls is that if you have a girl with onset of breast development before 8 years of age, menarche before 9.5 years of age, do not dismiss that this is physiological. Often the message comes ki aajkal sab development jaldi ho raha hai, nothing to worry. You have to assess the clinical picture, look at the breast stage, look at the ultrasound, look at the bone age, and then only you say, okay, this child requires follow-up, this child requires referral, this child requires immediate treatment. And we have got very good treatment available, which is to be given in selected cases, but when required, it has to be given. I'd like to thank all of you for patient hearing. Thank you.
Comments from the chairpersons, please.
Thank you, Dr. Anurag. As a gynecologist, at least I think we should be able to pick up and identify the cases who need treatment. We will refer our patient to endocrinologist, of course, but we need to identify definitely. Thank you for an excellent talk.
So hypothalamic hematoma, basically, the
Because
problem
you're
is
told now, don't
Yeah.
send patient.
So
surgery.
hypothalamic hematoma is not a pathology. It's a migrational defect. So hypothalamic neurons, instead of the hypothalamus, they are in the extra hypothalamic region. Now, because of that, the main problem which happens with that is that their inhibition goes off and they start to produce a lot of hormones, and that causes a lot of precocious puberty in that regard. So main treatment would be at the level of GnRH analogs alone, you will be able to take care of puberty. It's not a progressive disease. It's not a tumor which will grow. However, if you have a very large hematoma, we haven't seen many, if it's more than 8 centimeters, like a very big one, and the child has seizures because of that, that is the only indication where surgery is required. But I would say it would be less than 1% of these cases. So if you have a small 2-3 centimeter lesion sitting there, it's not going to progress. You don't need to do monitoring in terms of MRI. Treat precocious puberty because that's the only problem. If they have gelastic seizures, laughing like episodes, if they have persistent seizures, then maybe they require, but that's very, very rare.
Thank you.
Thank you so much, ma'am. Before we start the next session, I would like to invite Dr. Neena Gupta to say a few words.
So actually, both the talk were very informative, and it was beyond that we practice. Actually, we send the patients normally, these kind of patients we send. And the same thing, the Aarti told that we have to identify the correct patient and refer them in time. Because if it is late, then it's too late. तो दैट इज इम्पॉर्टेंट. और ये जो सर ने कहा कि सब कुछ जल्दी हो रहा है, तो ऐसे करके उसको छोड़ नहीं देना है कि प्रिकॉशियस प्यूबर्टी हो ही रही है. दैट इज वाज अ वेरी इंपॉर्टेंट मैसेज, because when we are late, then even in that case, for uterine development and breast development, the lecture Yutika have taken, there also we have to take action in time. Otherwise, uterine size and breast development both can be compromised. And the important thing she's told ki estrogen ko lagatar dena, we have to give estrogen continuously and see for the endometrial thickness at least 8 millimeter, then we have to give progesterone. And Dr. Anurag is always master in this field. I think kuch bhi pad lein, kuch bhi sun lein, hame unhi ke paas bhejna padega. So thank you for nice talks. Thank you.
Thank you, ma'am. A couple of words from Aarti, ma'am, please.
I'm too privileged working with them in hospital around 24/7. So I have no problem at all otherwise. But yes, as far as Yutika's talk is concerned, I would say that hypothalamic hypogonadism is one condition in which timely treatment can improve sexuality and the infertility status of the individual as well. And for Anurag, I don't have to say anything else, already been covered. Thank you so much.
Just a quick announcement before we start the next session. We have got the basic pediatric endocrinology, which was just released yesterday, available for sale with a very special discount here. It's available. So you can all have a look on it. We'll move forward to the next session.
Next session is an ovarian grand round. I would like to invite the chairpersons for the round. Dr. Vijay Jaiswal. Yes, for the panelists, Dr. Vijay Jaiswal, who has joined us from Meerut, Dr. Pradeep Kumar, who has joined us from Patna, Dr. Sugandha, who has joined us from Moradabad, and Dr. Vibha, who has joined us from Regency Hospital, Kanpur. I would like to invite Dr. Yotika ma'am and Alapan to start the session, please.
Thank you, Dr. Dhwani. So we'll be discussing about hyperandrogenism and oligomenorrhea in a case-based fashion in this grand round. For hyperandrogenism, the key features and pointers are hirsutism. That has to be objectively seen taking a proper Ferriman-Galloway score. Acne, severe recalcitrant acne, so not the mild acne, the acne for which you require treatment, and definitely if there are features of anovulation, irregular periods. So these are the pointers for hyperandrogenism. Severe hyperandrogenism would present with virilization, which is voice change, muscular habitat, and basically the full male habitus. And if it is rapidly progressive, it could be sinister. And other rare things like hidradenitis, suppurativa, and alopecia. Hirsutism, very important to differentiate between vellus hairs, hypertrichosis, and true hirsutism. So if you have excessive hairs, but the hairs are very thin, hypopigmented, and are present in the non-sexual areas of the body, like the arm and the lower legs. These are the areas, this is generally just the fine hairs, not hirsutism. Hypertrichosis can occur due to some sort of drugs and some conditions, and definitely, again, not happening in the sexual areas. And the sexual areas, which we look at the Ferriman-Galloway score and grade them. So if these are the 9 sexual areas, we all know about it. And if the hairs are here, we can grade them and objectively identify hirsutism. So anything below a score of 8 is not hirsutism. Mild, 8 to 15, and if it is more than 15, it is sort of diagnostic of hyperandrogenism. Anything very severe hirsutism, rapidly progressive in hirsutism, that needs a very urgent sort of an assessment. So if the Ferriman-Galloway score is less than 8, it's unlikely. Between 8 to 15, again, you need to confirm it by doing a total testosterone. No need to do a free testosterone. And then if it is more than 55 nanograms per deciliter, then we are looking at hyperandrogenism. If a very, above, then we are looking at hyperandrogenism here. And if it is very severe, say more than 15 Galloway score, again, in our resource poor setting, it's not needed to actually quantify it. It's obviously going to be hyperandrogenism, but you can confirm it. For coming on to the most common cause of hyperandrogenism in young women is polycystic ovarian syndromes. There are other causes as well. So it's a syndrome of both hyperandrogenism and anovulation. Unexplained hyperandrogenism, which is persistent for 2 years. So that is very important when we are looking in this age group. So between 12 to 18 years, it's very important to look at, and if it is in ovarian origin, then we say it's hyperandrogenism. Basically, what are the parameters? So these are the parameters that we'll be basically looking at. So features of hyperandrogenism, if it's absent, no workup is needed, but if there are features of virilization, definitely an adrenal and ovarian imaging needs to be done. If no features of virilization, then we go in for our hormonal workup, which is looking at other causes of anovulation, like the thyroid profile, prolactin, and DHEAS. DHEAS, if it is more than 700, we are looking at adrenal origin of the androgens, and then that needs to be ruled out. But if it is low, then workup for even 17 OHP is sometimes needed in some particular cases, and we'll be discussing about it. And if all those things turn out to be normal, then we've got the diagnosis of exclusion, which is the polycystic ovarian syndrome. Again, we'll be going to our cases. PCOS, again, for younger patients in the adolescent age group, we do not want to label these girls as PCOS because the diagnosis once is very difficult. And we have got these cases of hyperandrogenism of puberty. So we label them at risk of PCOS. And very commonly, these patients with lifestyle management and proper treatment, we are able to reverse their disease progression as well. That's why we treat them, but we don't label them. The other thing is a definite hyperandrogenic anovulation for more than 2 years. This is the case where we would want to basically definitely very aggressively treat them, because in hyperandrogenic state per se can induce PCOS like gonadotropin setup in them. So all the negative feedback mechanism of the pituitary is very much modified by testosterone, and a very high testosterone level in utero and during puberty can set up this gonadostat to male levels, and then they become very high LH level patients, and that's why then they turn out to be true PCOS. Severe hirsutism, and if there is anovulatory bleeding available, then also we need to actually treat them, and if there is associated obesity, metabolic syndrome, and those things.
Good afternoon, everyone. So after this excellent and crisp explanation about hyperandrogenism, we'll start with some cases. So our first case is a 14-year-old girl presented with hirsutism. The menarche was just 1 year back at the age of 13 years, and she is having periods in every 2 months. FGS score was done, it was around 6, and USG is showing a PCO appearance. Someone has labeled this child as PCOD. So, Dr. Bijay sir, I would like to know whether this diagnosis, you are agreeing with this.
No, absolutely not. We have to don't have to jump upon the diagnosis on the basis of ultrasound PCO appearance. First, so as ma'am has already discussed that hyperandrogenism and anovulation, and this unexplained hyperandrogenism to be persist for beyond 2 years, and it has to be proven that ovarian origin. Then only we are going to label the PCOS. So for this case, the FGS score is very low, that is less than 8. So that, and the symptoms are less than 1 year. So I don't think that we do have to label even PCOS.
As sir has extremely said, there is no role of PCO morphology in adolescence.
Yes.
And less than 8 FGS score is not a marker of hyperandrogenism in this case. So coming on to the next case, second case, a 14-year-old girl presented with hirsutism. Again, the menarche was 1 year before, and periods she is having every 2 months. Now there is some features of virilization in terms of muscularity, and FGS score is 18 this time. And someone has again labeled this child as PCOD. So Dr. Pradeep sir, I would like to know whether this diagnosis is correct or not.
Here what we see, the FGS score is significant. It is 18. And apart from that, virilization and masculinity is also there. So definitely we will be, worried and work up further. So what we see here, the testo is high, very high.
Yes.
It's more than 150 to 30 nanogram per deciliter. So we will further work up for whether it is from ovarian origin or adrenal origin. And so we go for imaging, and as well as we see how much the DHES level is. So it's too high. It's 900 nanogram. Let's see what is the imaging. So we'll definitely like to see the imaging.
So the imaging is showing.
Okay, it's a big mass. So definitely we'll be worried and we'll take the surgical consultation.
So the key thing here in both the cases is that the clinical parameters is very important. Ultrasound would label any hyperandrogenism as polycystic ovarian pattern. So that is not going to be the diagnostic. And if it is a rapidly progressive virilizing hyperandrogenism, it is always sinister and has to be worked up properly.
So the next case, a 15-year-old girl concerned about her hair. She has a normal menstrual cycle. There are some hair growth around the body, but FGS score was around 3. There are some family histories present. Dr. Sugandham, how would you like to proceed further in this case?
So the main concern here is of that of hair growth.
Yes.
So first, on clinical assessment, we need to see the foramen galvis score. which is fairly normal in this case. And we need to also look into what is the nature of hair. Is it vellus type of hair? Is there any family history of similar hair pattern in the family? And if it's only FGS of 3, the key message here would be not to work up in the, counsel the child, counsel the parents, and do not over investigate.
Sometimes some of these patients already come with an ultrasound done by a local doctor, and they are already labeled as polycystic ovarian syndrome. Very important for them to be counseled properly that this is normal hair growth, and that way to take the label away from PCO.
Also, some drug intake is very important in that perspective, whether patient has taken any drug like prednisolone, cyclosporine, or that. So this is a vellus hair, and diagnosis was hypertrichosis. So we will follow up the child in further. Now the next case, case number 4, is a 16-year-old girl presented with hirsutism, amenorrhea for the last 3 months. There was no obesity, no galactorrhea present in this child. Testosterone level done was 68, a bit high for this girl. And someone did a 17 OHP level, which seems to be pretty high, 600. So Dr. Vibha, I would like to know whether you will label this case as congenital adrenal hyperplasia or not.
Definitely not, because she has a clinical and as well as biochemical parameters of hyperandrogenism. And if we see the testosterone is more than 55, to definitely we look for the 17 OHP. But here the 17 OHP is like 600, which comes in the range which suggests us to go for the ACTH stimulation test. But here the girl is amenorrheic, and we are not aware that at what time she will ovulate. So this 17 OHP ideally should be done at the 2nd to 10th day of the periods at the 8 a.m. But there is a high possibility that during the ovulation, it will give the falsely high value. So along with the 17 OHP, we should always do the progesterone level. And if it is less than 175, then truly the value is high. But if the progesterone level is more than 175, it means the 17 OHP level has been done during the ovulation. So we should be very aware of at what time we are doing it.
Yeah. So moving on to the next case, case number 4, a 16-year-old girl presented with hirsutism, amenorrhea for the 3 months. There was no, okay, this is a similar case. And now that normal STCT is done, as you explained that this is normal, and progesterone level done, which was high. Probably the anovulation would be the reason. That is the reason because of this high 17 OHP level. So the next case, a 15-year-old.
17 OHP should be done in the proliferative phase of the cycle. And if the patient is amenorrheic, then do it with progesterone level to interpret it properly.
So for the next case, a 15-year-old girl presented with hirsutism. Menarche was at the age of 13.5 years and having periods every 3 months. She has a FGS score of 16 with severe acne. Testosterone level was 64, and USG is showing a PCOS appearance. Yeah. So, Dr. Bijay sir, I would like to know your opinion regarding this case.
Yes, thank you. If you are going to the problems what this young girl is having, that is, though has she attained menarche, that is 13.5 years, and at present she is 15 years. So we are going to only see the duration of the problem is less than 2 years, but we have to see the severity of the problem. That is menarche, and this menses is every 3 months. But you can see the FGS score, that is 16, that is beyond 15. So it means that she is having fair enough of hyperandrogenism. Testosterone 64 milligram per dl, it means that it is beyond 55 milligram per deciliter. And since there are so many symptoms, so USG is going to add up the diagnosis in this case. That's a PCOS appearance. Since we are not going to label this child as a PCOD, but in view of the severity of disease, we are very sure if it is not being treated at this point of time, probably in coming days, she is going to land up in PCOS. So this is very important, that this is a condition where the problem is less than 2 years of commencement of menarche, but since the severity is very high and the chances to land up in the PCOS is more, so we have to treat this child.
So this is at-risk PCOS, and we have to consider Rosipil for this child.
So it's very important in these patients, especially who have a total testosterone level above 55 nanograms per deciliter. And as sir said, with severe symptoms, oligomenoria, severe hirsutism, if we don't treat this child and keep her only on lifestyle management, we are not going to prevent PCOS. There is a proper chance that this patient, if she loses weight, gets her lifestyle corrected, and we correct her androgens, which is very important, we'll be able to prevent development of PCOS.
Okay, for the next case, 17-year-old girl presented with hirsutism. Menarche was at the age of 14 years, presented with oligomenorrhea. FGS score is with high 18. She had acne and BMI of 32. That categorizes her into a obesity category. Testosterone level was 72 nanogram per DL, and USG is showing again a PCOS appearance. Dr. Pradeep sir, I would like to know your treatment management plan from this case.
So this symptomatic child, rather adolescent. So what we see here, the gap is more than 2 years. So, and FGS score is significant. Testo is also significant. So definitely it is definite PCOD. And simultaneously the child is obese also. So we should treat this child. And what we do here, we should treat the children with lifestyle modification. We should add metformin as well as OCPs also we should give.
Yeah, this is a case of PCOS, and we have to, Sarah has explained that we have to treat with lifestyle modification, metformin and OCPs in this child. Ma'am, so after follow-up of this child, 3 months later, she had regular periods, but she loses her weight for 3 kg, but hirsutism is same again. And the parents are concerned about this thing. So,
Okay.
sir, what would be your advice regarding this case?
Yes. So what we see, there is a bit improvement, weight, the child losing the weight, but what we see, there is lag period. When you start treatment, there is lag period of almost 6 to 12 months. So what we should counsel the parents, if they are more concerned, the cosmetic measures we can offer.
Definitely, the life cycle of hairs is 6 monthly.
Yes.
So even before 6 months, we won't be able to actually correct the hirsutism. So they need a proper counseling to adhere to the treatment.
So again, on follow-up for after 6 months later, so now 9 months from the diagnosis, there is no improvement in hirsutism. The child has gained weight this time, and she is using the cosmetic measures. So, sir, I would like to know you would add any medication or something in this case.
Okay. So again, the concern is there. She's using cosmetic measures also. Weight gain is now here. So here we can consider adding some anti-androgens in the form of, spironolactone we can add, and we should see the improvement.
So out of 100, only about, say, 20 to 30% patients we require to add anti-androgen with that androgen levels. So we'll be able to prevent it in 70% by strictly adhering to the treatment.
So again, after follow-up 9 months later, now 1.5 years from the diagnosis, the patient is stable, having some intramenstrual bleeding, and patients are again concerned and worried. Sir, what would be your opinion regarding this to the parents?
So I think this intermenstrual bleeding can happen sometime. What we can do here, maybe we can, the adherence issue is there. So we can consider, improving the dose.
So it's basically any long-term treatment, the problem of compliance is always there. So proper counseling, understanding that if you skip the dose, you will have intermenstrual bleeding. Those things are very important. Yes. And that also leads to a poor response that we are seeing in this patient.
So now the follow-up is for more than 2.5 years, one year later. And now there is improvement in hirsutism, weight has decreased, and periods are regular.
Okay, so here the girl is improving, but what we have to do, don't have to stop the treatment. We should give post-menarchal 5 years. The treatment has to be continued.
So as Sarah has explained, we have to wait for at least 5 years from the menarche till the gynecological maturity, till we stop our treatment for consideration.
Yeah, that's a very, very common concern of the parents, that when we will be stopping. And even after stopping, there is a very high chance that the irregularity of period returns if the patient has not reached the goals of their weight and their lifestyle.
So moving on to the next case, a 16-year-old girl presented with hirsutism. Onset was 1 year ago, and she has also complaints about oligomenorrhea. Now this time she has severe menorrhagia and presented to us. Testosterone level was 90 nanogram per DL, and USG is showing a PCOS appearance. Dr. Sugandha ma'am, I would like to know your approach in terms of acute and the chronic management in this child.
So as we can see that she had oligomenorrhea to begin with, and her androgen levels testo was more than 55. And USG is also suggestive of a PCOD appearance. So this fits well with the picture of PCOD, but the current issue is that of menorrhagia. So here we need to first address the menorrhagia part and then later on treat the PCO part. So menorrhagia will be treated with high dose estrogen initially, and then later on maybe we have to give a combination with E+P.
So ma'am, any key messages from this case?
Basically, this patient has anovulation and anovulatory bleeding. So if we are using an estrogen progesterone combination, we have to use at least minimum of 30 micrograms of estrogen. That's why high dose estrogen has to be given in cyclical pattern. Or if there is a continuous bleeding, a patient has been bleeding for 10-20 days and bleeding did not stop, we have to use high dose progesterone to stop the bleeding and then transfer the patient into estrogen progesterone combination. Very important for these patients who have high testosterone level, not to give them only progesterone. Otherwise, we are not correcting, we are just symptomatically managing this patient. So looking at the overall picture, even though the concern was menorrhagia, we have to correct the testosterone. Otherwise, whenever we will stop, she will go back into the same vicious cycle of endometrial hyperplasia and heavy bleeding.
Yeah, so the next case, 16-year-old girl child presented with severe hirsutism. FGS score is 28. Parents are concerned as well as the child. She had complaints about oligomenorrhea, and testosterone level done was high, 110 nanogram per DL. So the USG is showing a PCOS appearance. Dr. Vibha, I would like to know your approach in this case.
So the patient is, the FG score of the patient is quite high. This is severe hyperandrogenism along with the oligomenorrhea. And biochemically, she has 110 testosterone, which is quite high. So for the management of this case, definitely we should start the E+P combination, because the estrogen here will increase the this SHBG level, which will decrease the free testosterone and which will help in decreasing the hirsutism. So definitely E+P, the therapy will help the patient.
So here we are presenting these cases in a short manner because all the other things have been ruled out. So there, we've ruled out all the adrenal causes and other things. And this is an isolated ovarian hyperandrogenism. In these cases, if we want to decrease the testosterone levels because they are really high, we have to give them a continuous estrogen progesterone with a 3-monthly regimen, and then only we'll be able to sort it out with this or add anti-androgen because it's quite high.
Yes, so the next case, a 17-year-old girl child presented with hirsutism, and it presented immediately after menarche. Now it is rapidly progressing for last 6 months. She had also amenorrhea, muscularity and voice change in terms of virilization, and testosterone level was 200 nanogram per DL in this child. Dr. Vijay sir, I would like to know your plan of management in this case.
Yes, so what I can see that progression is very rapid, that is rapidly progressive for last 6 months. Amenorrhea to muscularity and even voice change. It means that there is hyperandrogenism, and we can see that testosterone level is very high. So I can think that there can be quite severe disease, and this child to be evaluated for maybe say ADCC or something like that. So imaging is really very must.
So this is the USG picture of that girl, showing a large ovary.
Yes.
Probably the hypothecosis would be the reason that could cause this kind of picture in this child.
So after ruling out adrenal and other causes, if there is isolated ovarian hyperandrogenism of male levels, then with such large ovaries, then diagnosis of hyperthecosis is made. And typically these patients have a normal onset of puberty and a secondary sort of appearance, very much like something going wrong with the ovaries here.
So now the child is on estrogen progesterone preparation and spironolactone, but she had the persistent symptoms. Virilization is still progressive. Testosterone level is now 240 nanogram per DL. Sir, what would be your plan?
Yes, I think we have to continue the medical management, but the agony of the parents and what we can see here, that spironolactone and other anti-androgen to be added. Despite of that, if the patient's symptoms are not improving, probably there can be some other maneuver that is dot therapy. That is, we are going to make some holes on the ovary to reduce the volume of that. Even wedge resection has been provided. So that thing we have to think. Otherwise, on the medical management, if they are not responding to these usual therapy, GnRH analog therapy on a 3-monthly basis can be tried, or initially monthly basis. We have to see the response and then we have to shift on the.
So they've got a very high volume of theca cells, which are still under the control of the gonadotropins. So if we shut down the gonadotropins, we'll be able to, treat this condition. And then the ovarian size also decreases. And when you stop it further, it doesn't go back to the previous pattern.
And also one more important thing to add, estrogen in this child, so she doesn't have any deficiency, and considering her bone in this status. So over to you, ma'am.
So again, for the next round, we've got oligomenorrhea. Again, the diagnosis of oligomenorrhea is basically the symptom of, has to take into account what is her postmenarcheal age. So in the first year, if somebody is having less than 4 periods, in the second to fourth year, if it is less than 6 periods, and in the 5th year, less than 8 periods, we say it is oligomenorrhea. And after 5 years, it's the adult diagnosis. We say amenorrhea if it is no periods by 15 years of age or more than 3 years of tilaki. Secondary, if it is more than 3 months after the onset of periods, we say it is basically secondary amenorrhea. So oligomenorrhea, very important in this age group. We have to exclude pregnancy, other causes of anovulation like hypothyroidism, hyperprolactinemia, which is also very common. Now, the key in precocious puberty, we were talking about LH as being the key hormone. The key hormone here is the FSH. And if FSH is high, we are looking at gonads that are not working. It is ovarian insufficiency. And the workup here needs to be ruled out any sort of Turner syndrome or other causes of premature ovarian insufficiency, and also an autoimmune workup. If the FSH level is normal or low, then we have to assess clinically or by doing this estrogen status. So look at the breast, endometrium, and vaginal mucosa. Hypoestrogenic, we need to do some screening tests, any other causes of functional hypothalamic amenorrhea, like chronic disorders. And especially celiac disease presents in this manner. If there is anemia and hypogonadotrophic hypogonadism here that is happening as secondary amenorrhea. If it is normal, so these are the cases where you have to look at the hypothalamic pituitary axis, and you need to do the MRI to rule out any acquired causes of dysfunction here, maybe tumor, infection, or pituitary hypophysitis, lymphocytic hypophysitis. Those things present in this manner. And if all these things are normal, if there are any additional hyperandrogenic features, even PCOS presents as primary amenorrhea. So we need to look for anovulation happening due to hyperandrogenism as one of the cause of oligomenorrhea here. If the FGS is above 8 and if the testosterone is high, maybe that is the cause of oligomenorrhea. If there is, then workup. Now, if there is no response to, so you can have secondary amenorrhea due to some uterine cause as well. So if you are having endometritis or intrauterine adhesions due to tuberculosis, we see all those things happening. So they will not have any response to estrogen and progesterone withdrawal. So that would be a cause of secondary amenorrhea.
So I'll start with some cases. Case number 10, 15-year-old girl concerned about her scanty periods, menarche at the age of 13 years, and she is having periods every 6 weeks of duration of 1 day. So she was advised estrogen and progesterone preparation. Dr. Pradeep sir, I would like to know whether this thing is right or you would like to modify anything in this case.
Okay, so as ma'am has reviewed the initial slides, that we have to first define the oligomenorrhea. What we see here, she's having, after 13 years, she's right now 15 years after menarche, almost 2 years has happened. And she had a period of 6 weeks, every 6 weeks, which will come annually around 9. Okay. So anything, she is more than 2 years, 2 to 4 years. So if it is less than 6, then only we can label it as oligomenorrhea. Here it is approx 9 or more. So the workup is not needed. So unnecessarily she was advised OCPs.
Yeah, we will keep her in follow-up to see
Yes.
the progression or improvement and reassurance. That is what is needed in this patient. Scanty periods make these patients really very much worried.
Yes.
And that is why maybe sometimes for scanty periods, we do a few tests, but definitely most of the patients, we don't need to provide them treatment.
Okay. So the next case, a 17-year-old girl, she had menarche 4 years ago. That means at the age of 13 years, she's having now infrequent periods and there is no periods for the last 3 months. She had lost some weight and having some lethargy. Baseline investigation in terms of LH, FSH and estradiol has been done, showing a low levels and diagnosed as hypothalamic amenorrhea. But now the child has presented to us with complaints of seizure. So Dr. Sugandha ma'am, I would like to know where was the pothole in this case?
So to begin with, she had oligomenorrhea.
Yes.
And since her basic profile showed low gonadotropin levels and a low estrogen, hypoestrogenic state, first we need to do, before labeling her as hypothalamic amenorrhea, we need to look at the some baseline testing, and also MRI of the head will be essential to look at the pituitary. And do we have?
So yes, we have the MRI of the child.
Okay, so here there is a definite mass, and there is history of seizures also.
Yes.
So, so basically, before labeling the child as functional amenorrhea, we should, since it's a diagnosis of exclusion, we should always look at the pituitary to rule out any serious.
So hypogonadotropic hypogonadism, always get an imaging done to actually label, before labeling as functional hypothalamic amenorrhea.
Yes. So the next case, a 17-year-old girl presented with secondary amenorrhea. Menarche has at the age of 12 years and she is having periods every 2 monthly. LH-FSH is at the normal level, 4.4 and 4.9 respectively. Breast is normal and FGS score is 4. So Viva, I would like to know, how do you approach this case?
So at the age of 17 years, and that is more than 5 years of the menarche, and she is having 6 periods per year. So definitely she is having oligomenorrhea along with the normal FSH. So as we go with the algorithm, we have to see what is the estrogen status. And for the estrogen status, we have to examine the breasts first, whether they are soft or the firm. That will tell us whether there is low estrogen or not. Another thing, we can look at the vaginal mucosa, or we can go for the USG endometrium. If the endometrium thickness is more than 6 mm, then definitely it shows there is a good estrogen exposure. And as her FGS score is 4, so definitely she is not having any hyperandrogenic features. So for that, we can go for this progesterone withdrawal in this case and see what happened. Definitely after the progesterone withdrawal, she will have the withdrawal bleeding. And so definitely this is a case of annual cycle, and this is how it's managed.
Yes. So
we have, as adult gynecologists, we label all these patients as a 4th type of PCOS because they have anovulation but no hyperandrogenism. But many of these girls have actually type 1 anovulation, which is, there is some dysfunction in the hypothalamic pituitary axis. It could be functional, it could be eating disorders, it could be a lot of other things that can lead to that kind of anovulation. And at 17 years, we will definitely want to correct her periods to avoid development of endometrial hyperplasia and problems related with anovulation.
okay, so for the next case, a 16-year-old girl present, her menarche was at the age of 11 years and having a periods 1 monthly. She has FSH, now she had having a secondary amenorrhea. FSH LH level is quite normal, base is normal stage, and FGS score was 1. But there was no response to progesterone in comparison to the previous case. So Dr. Vijay sir, I would like to know, how do you approach this case?
Yes, if I can see here that the age appropriate menarche has been achieved and the periods were initially regular. The hormones, that is FSH, LH, they all are normal and even other things are normal. There is no hyperandrogenic state, at least clinically. So no response to progesterone. So I have to see there can be other history of systemic disorder or something like that. So I want to have infection or some other thing. So again, so we have to see that if any patient is coming to me like oligomenorrhea, so first we have to exclude the pregnancy, hypothyroidism, hyperprolactemia. We have measured FSH level, and if this is terminally high, it is probably primary ovarian failure or ovarian insufficiency, where we are going to rule out the Turner and autoimmune workup. On the other hand, if FSH is normal or low, like in this case, so that was normal, we have done the estrogen status, and this estrogen status was also normal. Then we have to see whether your patient is responsive to your estrogen progesterone response. So again, she is not responsive. So then we have to see that what is the structural cause. So in nutshell, so what I'm going to see here, that the local thing has been done, a hysteroscopy. So I would like to see that what is, so again, we can see now that this is a local cause, that is genital tuberculosis, that is infection with mycobacteria. So again, this is science prevailed that we have to go to the detail of the things, that how, what is the expected response once you are giving your drug. And if that is not there, that is, there is no clinical correlation with investigation and your drug response, then we have to look out the other causes.
Yes.
So that is the
So this is one case of non-endocrine cause of secondary amenorrhea. So this patient should be referred for a gynecological evaluation. So all her clinical, hormonal and functional workups are all normal. And when we did a estrogen progesterone withdrawal, there was no bleeding. So it was a local cause.
So the next case, a 15-year-old girl presented with primary amenorrhea, breast stage 1, pubic hair stage 1. And he has height of 152 centimeter, weight of 52 kilogram. FSH level and LH level was quite high for this child, and estrogen was undetectable. She had some mild hirsutism, large cysts present in her ovary, and has a karyotype of 46XX. So Dr. Pradeep sir, I would like to know any significant history you want to ask, especially to the patients or her parents.
Okay, so definitely what we see here, she is still pre-pubertal, and so she has quite good height, 152 centimeter, and okay, weight is okay. FSH, LH is very, it's high, and what is important is estradiol is very low. So what we see, the picture is like hypo, and she's having mild hyperandrogenism also. The karyotype is phenotypically she is female, like genetically, and she's having large cyst also. So as in review, ma'am said, the initial phase of the follicular development, in later stage, the LH and estradiol is more important. Initially, FSH is important, so that could have increased the size of cyst. So here, what we have to do, we have to extensively take the history. We can plan genetic workup. We can think about steroidogenic defect also. And what we see here, clearly, she is having maternal virilization. And the child had height, a good height also.
Yes.
So if maternal virilization is there, so she might have during her gestational period, there could have been some androgenic effect, or maybe some androgen would not have converted into estradiol. So I'll definitely think about aromatase sort of deficiency, aromatase deficiency.
So key feature here was the ovaries responding, and
Yes.
still estrogen is not being produced.
Not being produced.
So you've got large cysts, so FSH is being produced, but the functional hormone is not being produced. So if you've got a patient with this kind of picture, that is sometimes sort of a resistant ovary syndrome, which can happen in say aromatase deficiency. Normally all patients with hypogonadism have very small ovaries, very small streak ovaries. Here if you've got ovaries with cyst, or a polycystic pattern of ovary in a setting of a high FSH, you should look for functional defects in the, estrogen, which is aromatase deficiency, one of the common things.
So the
But
yes, sir. Okay. So the next case, 17-year-old girl child presented with primary amenorrhea. Now the breast stage is 4, PVK stage is 4. Height is a bit taller, 168 centimeter, and weight of 52 kg. Here again, the FSH and LH level was high and estrogen level was undetectable. Dr. Sugandha ma'am, I would like to know your approach in this case.
So what we can see from the clinical picture is that this girl, she has primary amenorrhea, and as Dr. Alapan has mentioned, she appears to be tall. So here on the workup, when we see the FSH levels, it's pretty high. So any tall girl with primary amenorrhea, with high FSH, we should always look at the karyotype and keep a possibility of XY-DSD. And so
yes, we have the karyotype, and the karyotype is 46XY in this child.
So the key message here would be any tall girl with primary amenorrhea, do FSH, and if the FSH is high, then consider doing a karyotype.
So this is a case of SRY defect where male individual, and gonadectomy is advised further in this case. So the next case, 16-year-old girl presented with primary amenorrhea, breast stage 1, PVK stage 1, height of 168 centimeter, weight of 52 kg. Again, the LH FSH was high, estrogen was undetectable. Oh, yes. Sorry.
I think you go back to the previous
Previous,
case. Case 15, the last slide. So in this particular patient, she attained her puberty on her own, even when her karyotype was 46, XY karyotype. So there was some ovarian function, and yet her karyotype was this thing. So she had a SRY defect. And next slide, please. So any tall girl with premature ovarian insufficiency, look for XY-DST, because they can sometimes enter into puberty as well. So they do not present with completely delayed puberty, because some ovarian function is attained during embryogenesis in these patients. Next slide.
So next case, a 16-year-old girl presented with primary amenorrhea, breast stage 1 and PVK stage 1. Height is on the taller side, 168 centimeter, weight of 52 kg. FSH-LH was again high with undetectable estrogen level. Karyotype was 46XY.
So this case is very much similar to the previous case, but here we can see there is no pubertal development in the girl. She has a B1, P1 and primary amenorrhea. So as the karyotype is XY, so definitely she XYDSD, but she has this female phenotype. So we have to look for the stereogenic defect. At this age, the stereogenic that can present could be 17 beta HSD, and if the blood pressure is higher, then it could be the 17 hydroxylase deficiency.
And definitely more common, So it is XY-DSD, the entire ovarian function will be gone. So that's why she had this thing, delayed puberty. So we have to look at all the other causes, and one of in this, because she had inguinal gonads, you were able to pinpoint.
Okay, that's all for this. Thank you.
So I think the key messages in these patients of oligomenorrhea presenting is to look for their puberty and look for what is the age of menarche, and then we can have from mild to very severe cases. Just by clinical diagnosis, we can pinpoint the diagnosis. Thank you.
Thank you. Thank you.
So thanks a lot, all the chairpersons, Dr. Vibha, Dr. Sugandha, Dr. Pradeep, and Dr. Vijay. And thanks, Dr. Yutika and Alapan, for really having this wonderful discussion on ovarian disorders. We will be now breaking for lunch. So we'll be closing the streaming now, and we will have the second stream starting from 2 o'clock, which will be covering 3 important panels on calcium. growth and electrolyte disorder. So we'll have lunch now and we'll join back at 2 o'clock. Thank you all of you for patient hearing.